Good morning, everyone.
Good morning.
Oh, good morning. Yay. Um, Welcome to South Africa. Welcome to Cape Town and welcome to Into 2025 Community Day. I'd just like to say thank you to everyone who has joined us here today, traveling far, traveling close, but nonetheless, you're here to share a very, very special experience. Not only is Into an amazing opportunity, an amazing experience within itself, but today is all about us as community. So, just some housekeeping and some information. If you haven't received your registration yet, you're welcome to do so at tea time or lunchtime. We will have a visual artist who will be drawing up and making notes, sitting comfortably at the back there. Thank you, Kaylee. Just so you know, we will also be taking photos and videos for our socials and for media. If you're not comfortable, please do just hide your face or let the person know if you're not comfy. We also are encouraging people to post on your socials, hashtag Into 2025, hashtag Community Day 2025. And also, we will be having a short session with our lovely Sarah Whipple, who will do some information on overdose prevention. We are encouraging everyone to please come speak to us if you need overdose prevention, naloxone, because we want to keep each other safe and have an incredible conference and minimize risks because it is a conference around harm reduction, health, and of course us as people who use drugs. There are also harm reduction commodities available. Needles and syringes are available along with other safe injecting equipment in room 7, which is just down here. There are also stimulant packs available. You can find them at the Sandpud tabletop from tomorrow, but if you do need now, we do have the lovely Shanae at the back in the leopard print, looking all fabulous, who does have some stimulant packs as well. I'd just like to say a big thank you to Insu and the Asham team, but most importantly to the incredible community committee, who without everyone in there, without the community, we wouldn't be able to do what we are doing today. I may get slightly emotional because this is very special, but most importantly today is our day. It's a day where we can be proud as people who use drugs and showcase our work. And I think something that's really special is that this is the first time this INSU on an international space has been in our region in Africa. So we have a very special start to the Community Day, which is going to be showcasing work done by people who use drugs-led networks based in Africa. But we will also then have an incredible session following that on stimulants and harm reduction. Excuse me while I look at my notes. So mental health and stimulants, we'll have a discussion around. We will also be celebrating the Jude Byrne Emerging Female Leader Awards. So those amazing women will be announced today. We will also, after lunch, have a session on peer-led responses to incarceration. And last but not least, we will have a session on community-led research and its role in advocacy. And that's quite interesting because the community-led research session links in quite nicely with the early to mid-career research and community networking event, which will happen after today's Community Day from 4 p.m. to 5:30. So please do hang around for that. It's also quite wonderful. And then we will end the day with from 5:30 to 7 for those who are interested with the prisons networking and panel discussion. If you do have any questions, there is space within the conference, within the Community Day agenda, to ask questions, but I do encourage everyone to chat to each other, spend time with each other, get to know each other, and there is also a welcoming and first-timers meetup tomorrow during the tea break and during lunch. So if this is your first INSU, welcome, 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 and please don't be shy, don't be scared. There's no such thing as silly questions. There might be silly answers, but there's no silly questions. And we just want to welcome all of our community, and big, big, big thank you to all that are here and all that organized. So without further ado, I'm going to ask the wonderful Ahmed Saeed from the African Network of People Who Use Drugs to share a very special video with us and a little something. Thank you.
Distinguished delegates, ladies and gentlemen, welcome to the 13th International Conference for Health and Hepatitis C here in Cape Town and in Africa. My name is Ahmed Said, the Regional Coordinator for the African Network of People Who Use Drugs. And I am really excited to show you the great work done by the community-led organization in African region. Here you go. The networks of people who use drugs are on the front line of the public health response to HIV and viral hepatitis. We are giving out sterile needles and syringes and other harm reduction materials. With the help of Unitide-funded hepatitis C portfolio, drug user-led networks in Egypt, Nigeria, South Africa, and Tanzania are studying the use of low dead space needles and syringes. Our networks are also at the heart of the response to opioid overdose, distributing naloxone, educating our peers, and stepping in to save community lives. Our activists are also working to reach people with opioid dependence to highlight the benefits of opioid agonist maintenance treatment like methadone and buprenorphine. Once again, with the help of the Unitide study, Egypt, Nigeria, and Tanzania are studying the use of long-acting depot buprenorphine in low and middle income countries. Our groups are also reaching out to our peers with dried blood spot testing and helping them access HIV and HCV treatment and support with other medical conditions. Our peers also deliver wound care treatments on an outreach basis, helping to address injuries linked to injecting drug use or living outdoors or in exposed settings. Our networks and their leaders are organizing with other key populations. We are organizing together within the African region and supporting a new generation of drug use-led networks in Africa, including Zambia, Egypt, and Ethiopia. Our drug user groups are planning together, helping develop the quality of drug services and advocating with the policymakers and state authorities. Across the region, our advocates are trusted voices speaking about our communities' living experiences from the local through to the global. You are joining the region where the networks of people who use drugs are flourishing and making credible impact on the ground. Welcome and have an opportunity to learn more about the amazing work done by the people who use drugs in Africa. Welcome to 2025 here in Cape Town.
No tears, no tears. Truly, truly wonderful, and thank you. And what a beautiful way to introduce and bring and start this day. I would like to now introduce our wonderful Natalie Jacobs from South African Network of People Who Use Drugs.
Hi, everybody. Good morning. So my presentation is on human rights work, referral systems, and legal services. Next slide, please. Okay, so basically, working as a community linkage officer, I go into the community and engage with the community to find out what issues are that they are having in the community where human rights violations are concerned. So this is the four human rights violations that are occurring like continuously in different areas, different hotspots. So the first one is police brutality, denial of access to healthcare services, child removal, as well as gender-based violence. Next slide. Okay, so the objective is that what we want to achieve is to help our community get justice, to stop abuse or harm done to them, as well as to connect the person to the right services, help, to make their voices being heard and not being suppressed, to support them through the process by going with them when they have consultation meetings if they are linked to legal services, assisting them and finding out how to go about if they want to take the case further, to collect proof for change, as well as to build trust in the community. So the referral steps that I follow is to ensure the person are safe and that I have their consent, identify and document the violation, access urgent and needs. For example, it is if they were brutally assaulted or a person were raped or with gender-based violence concern, that needs immediate attention, as well as prepare a referral form or case summary to make sure that either legal services or health services know what the whole situation is about, and then ask permission if case can be referred. That is the most important thing, that you have to ask the community member, do you want to go forward with the case? Are you prepared, especially where police brutality is concerned? Then we follow-ups to make sure that the client received the services, that they are initiated onto what treatment at the healthcare facilities. Also, the report the facts. Make sure that you have the facts, the date, the time, the name, who was involved, what happened, where it happened, how long it was. So basically, you need to make sure that the facts are correct, and that of the PWOD community and not of your own words. Then also make an appointment for a consultation meeting with. So I work with pro bono lawyers. So in order for me to get a consultation meeting, I have to wait for them to have availability. But also with the relationship that I build with them, they know that community members, they move, especially when you are homeless and you're living on the street, that it's not easy allocating them again. So in order for me so they go according to the community needs. So if I do get the client, then I can bring them immediately for that consultation meeting without them giving me a date. And then, like I said, accompany the person to the consultation meeting, and then also make sure that the client understand that the consultation meeting is to find out if the case are winnable, have you got enough proof, or do you need more proof, or do you need more witnesses that can validate your case. So the outcomes based on a case that I had was from a child removal. So basically what happened here was a child was forcibly removed from his caregiver, which the child sees as his grandfather. And then while busy dressing the child, it just because he was the day before it, his parents took him to the clinic for, and he was sorry, madam, I'm just a bit nervous. At the clinic, they said he had diarrhea. So while busy with him, it just one of the social workers came and was accompanied by a Sea Point police officer, and they forcefully removed the child from the caregiver without any. So basically, it just his lower part of his body was naked. They just took him with no clothes, nothing on, and then furthermore, it just what happened is it just they had to put him into a not orphanage, like at the social workers. They had to put him in the area where his parents was, but they took him out of the area. So they went to allocate him in Paul, which was a very, very far away for parents to go and visit him. Then, due to that, we went to the social workers' offices, and the child was not even registered on the data system to say that he can be removed from his parency. So that was investigation was done. The two people that was involved, the social workers that was involved, they were suspended until further notice. So, and basically, it is at the end of the day, due to consultation meetings at pro bono, the parents got the child back. So he is with him at speaking like at this moment. So that was my first case, just where child removal was concerned, that I was able to get the child back to the parents. Okay, can you move on to the next slide, please? Thank you. Okay, so my achievements that I did was so I am part of the Cluster Clinical Committee Board, which I will be able to have access for lost to found clients, as well as to make the second 95 target, which is adherence to treatment for HIV, whichever. So we are a bit short on the second 95. So being on the committee, on the clinical committee, I will have access to lost and found clients, and so that we can allocate them. And then also it is for the dignity, diversity and policy training and sensitization, which I sensitize Chapel Street Clinic and Lady Michaelis, which I have a very good relationship with them, where PWIT community can access services without being stigmatized and without being decriminalized. They can access services without having a formal address, or they can go without that. So they will be helped, they won't be turned away. And then also I am currently also did the application for the CPF, which is the Community Police Forum. Thank you. Questions and answers?
Thank you so much, Nats. I'm now going to ask Aloha Amiola to come and join us up from Youth Rise in Nigeria.
Good morning, everybody. Thank you, Angie. Alao Amiola Oluwafisayo. That's my name, and I work for Youth Rights Nigeria. My presentation is going to be a video documentary, a short video documentary of what we've been doing in Nigeria. But this time around, it's the advocacy video documentary that that was done before arm reduction was fully approved in Nigeria. And these are part of the things that led to and birthed the full start of arm reduction in Nigeria. Thank you so much.
Nigeria
is known to have the fourth highest number
of people living with HIV and AIDS in the world,
with about 1.9 million people living with HIV.
Progress has been made in many aspects,
especially as it relates to the effectiveness of the multi-sectorial response. However,
Injecting drug use among key populations is still a growing concern.
injecting drug use has been reported in every state of Nigeria. Based on available data, the practice contributes about 9% of the annual new HIV infection in the country. UDRISE Nigeria operates a one-stop shop where comprehensive health services are provided to people who use drugs. One of our clients, named Adamu, who recently tested HIV positive, shared his experience.
Now my oga show me that and say, if I do that, do this kind thing, she no go allow to anything where he say go pay you for body, she no go hear that one. I get HIV for my body. I never stop the sharing with you.
A visit to some injecting locations showed some have their peers inject them and are frequent in sharing and the reuse of needles.
I started this almost getting to 8 years. I was injecting myself. I see that from my friends. So I asked him what is that. He told me it is drugs. And I tell him to give me. When he gave me, I test it and I feel it. Because the thing entered my blood, I couldn't do without it. So if I see my friend or any one of my nigga who have it, I will tell him please do it and remain small for me. That's how I started.
Our team moves to Kano. We met Shuaibo from Fawida.
When you reach Sabangari market, it's just easily to get this pentazocine or ketamine injection. Before, it's not anybody does not this injection. But gradually, when you start, it's very hardly to stop.
Research has shown that harm reduction, specifically opioid substitution therapy as well as needle and syringe programs, can help to reduce new infection by more than 50%. And that's what we are missing in this country because we've not been able to make significant progress.
Injecting drug use is prevalent in Nigeria. There is an urgent need for a comprehensive response that will include the full complement of harm reduction services. Together, we can work towards a country with zero new HIV infections.
Thank you, everybody.
Thank you so much. I now would like to invite Armand up. It's quite a beautiful story. In this case, Armand has been trying to come to this conference for a good few years. And I am really, really happy that he's been able to join us. And I can't see him in the room. Wait. Ha, yes, Armand. Thank you so much. Oh, from Burundi.
Hello, everyone. As it is my first time to participate in this conference, my name is Armand Savaganwa. I'm from Burundi. I tried to participate in this conference since 2023, but my visa was always denied. So my title is that one, Burundian harm reduction from Genesis up to now. As you see, the presenter is me. I'm working at INSS Santé Plus, which is an organization which is fighting against HIV, hepatitis, STIs, tuberculosis since 1993. Okay. Burundi in global harm reduction landscape begins by drug use caused by many years of war, cyclical war since independence in 1962. We can find such situation in many African countries. Many children lost their parents killed, they lost assistance, and find themselves in the street living in the extreme poverty. They start using drugs in their young age. In Burundi, viral hepatitis and HIV remain significant public health challenges, especially among people who use drugs. For decades, responses to drug use were punitive, with little attention to harm reduction or hepatitis prevention. The recognition of hepatitis as a growing burden creates a turning point for integrating harm reduction into national health priorities. Our government must make harm reduction and hepatitis a priority. Problem statement. Till now, in our country, we don't have a global seroprevalence rate of hepatitis, whether in general or key populations. The data that we have is only from PROT studies. The Belgian Bib Ranger and his colleagues, during their research of the prevalence of hepatitis B and C among people working at the Lake Tanganyika, synthesizing data mainly from the work of Professors Ntagirabiri and Nyongabo and their colleagues, present us with a worrying situation. In 2018, the seroprevalence of hepatitis B was 4.6%. It was 5.4% in men and 3.9% in women, with a difference that was not statistically significant. In the same year, the seroprevalence of anti-HCV antibodies was 8.2%. It was 8.2% in men and 8.1% in women, with a difference that was not statistically significant. Milestones. I present a narrative review of harm reduction initiatives in Burundi from their inception to the present. Information is drawn from pragmatic reports, community-led initiatives like BAPUD peer work, and collaborations with civil society and health authorities. Key milestones are analyzed, including hepatitis testing, co-infection of HIV hepatitis treatment integration, advocacy efforts, and service delivery models. Community engagement. INSS Santé Plus is running different projects that focus on hepatitis screening awareness in partnership with some community-led organizations like BAPUD. Peer educators are involved to help raise awareness for screening of our beneficiaries. Peer education helps during outreach screening by reducing stigma in our services. This year, in August 2025, our country has just acquired its first opioid agonist treatment center, a thing that was advocating for many years. This will reduce hepatitis rate. This will reduce hepatitis rate, which shows hepatitis B prevalence of 3.7% from a recent survey that we ran INSS Santé Plus among key populations. We also hope that HIV prevalence rate of 15.3% among people who use drugs in a survey of 2021 will reduce. Challenges. Till now, for hepatitis positive cases, free treatment is only available for people living with HIV. In these times of reduction of international aid, our country is at a high risk of not achieving the WHO target of eliminating HIV, hepatitis, tuberculosis, and STIs by 2030. Conclusion. Sustained investment, political commitment, and regional collaborations. Here, I think in this conference, we will hear some presentations saying that some countries are reaching micro-elimination of hepatitis, but you've seen that we don't even know how many people is living with it in our country. So we need these regional collaborations, whether in advocacy or support. Regional collaboration are needed to scale up services and assure that no one is left behind in the global fight against HIV, hepatitis, tuberculosis, and STIs. Those initiatives that I've shown you are being run by INSS Santé Plus, funded by Coalition Plus France, but in partnership with Ministry of Health, the Department of Fighting Against HIV, STI, and Hepatitis, but also in partnership with the main Burundian community-led organization of people who use drugs, BAPUD. So, thank you. This is what I have to tell you, and thank you so much.
Thank you so much, Armand. Next, I would like to invite okay, all right. There have been a little bit of adaptations. So next, I would like to invite the lovely Anidi Akpan, all the way from Nigeria, to come and share a bit from his side. Thank you. Oh, by the way, there is a translation option as well. The QR code for translation is on the door outside if you need it. Thank you.
Good morning. Good morning, everyone. My name is Anedi Akpan. I'm from Nigeria. I lead the Nigeria Drug User Network. It's registered with the government of Nigeria's Drug Harm Reduction Advocacy Network, Nigeria. And today we'll be talking about sustaining the advocacy for decriminalization of drug use. We realize that decriminalization of drug use is causing a lot of problems for us as a community of people who use drugs in Nigeria in terms of being able to access services, in terms of being able to advocate more freely for harm reduction services to be available for people who use drugs. And so for the past 3 years, we've been working on decriminalizing drug use, whether using the legal system or developing relationships that helps to reduce, criminalization of people who use drugs. Next. So I'm just going to take us through this. Next. Okay. Oh, thank you. Okay, so I'll just basically talk about DRAN. It's a network of drug user community-led organizations in Nigeria. Our main focus is on advocacy. We felt we needed a platform where people who use drugs-led community organizations could come together and speak in one voice at national forums. So we've been at the forefront of advocacy for the Needlands Range program. In the first country dialogue, DRAN supported 2 members of the community of people who inject drugs to come for the country dialogue, because as at then, our country kept arguing that we did not have people who inject drugs, and so there was really no need for a harm reduction program. And that is why, as at 2018, in the Global Fund country grant, there was no harm reduction service. We started a harm reduction specifically in 2019 with the pilot needle syringe program, and DRAN was instrumental for that. Now we have the opioid agonist maintenance treatment program. It's called medication-assisted treatment program in Nigeria. And we also have naloxone in the country, and we've been working really with the principal recipients on the Global Fund grant to see how we can make the naloxone not just available at the one-stop shops of the Global Fund, but available in the community. So we are a critical stakeholder in the HIV and the health sector response. We started with HIV, but right now we are going to health sector response. We are moving to interventions, social interventions, including occupational therapy. So we build these relationships with government. We try to integrate our work with what government is doing, and also try to seek out opportunities where we can support people who use drugs on government-funded programs. Okay, so this is members. We had a cultural day on the Love Alliance project. These are the few members who were there. And this has been the milestone. So we've succeeded in signing a memorandum of understanding with the National Human Rights Commission of Nigeria. And that memorandum is supposed to help us do two things, and which, of course, is what we have been working on lately. First is to include human rights violations and of people who use drugs, including women who use drugs, into the National Human Rights Reporting System. So very soon, if you open to the National Human Rights site in Nigeria, you'll see reports of violations of people who use drugs. We felt this would be a way of entrenching accountability into national systems of human rights. And then, so we had a memorandum, and that memorandum has been the basis for most of the activities we've had with the National Human Rights Commission, including the support to establish a subnational harm reduction committees in the states to deepen the advocacy at subnational level. Okay, I see on that table is the Commissioner for Health of Gombe State. Yeah, he understands. Yeah. All right, so we've also contributed at public hearings. We've been looking at how to decriminalize drugs, and so we've been searching out all opportunities. In 2024, that's last year, a senator of the National Assembly of Nigeria proposed a bill for the establishment of the National Institute for Drug Awareness and Rehabilitation. We felt as a network that if this institute was created and had its focus, like was planned, on public health, that if we were able to influence some of the provisions, that it will help to remove criminal penalties, which is part of the Drug Law Enforcement Agency bill, and put it in the health, public health sphere. And so we supported the bill. We went to the National Assembly, that is me, yeah, at the National Assembly, yeah, presenting our memo to the members of the Committee on Drugs and Narcotics. And hopefully, we've had progress. The bill has passed through second reading. I must mention also that Youth Rights was greatly involved in this too. And we are hoping that it comes through. Also, because of this, and considering that the National Human Rights Commission is the designated human rights responder on the Global Fund Grant Cycle 7, we've been able to take part in the development of the medication-assisted treatment bill. And as some of the sub-provisions of the bill is to decriminalize drug use by making recommendations for the amendment of the National Drug Law Enforcement Agency Act and the Dangerous Drug Act in Nigeria. This is the picture from the presentation at the National Assembly. We were with partners, and this is during the signing of the Memorandum of Understanding with the National Human Rights Commission. We are with the Executive Secretary of the National Human Rights Commission in the middle, with the red cap, Barrister Ojukwu. And this is when we held a meeting with a community of people who use drugs to look at the indicators for reporting of human rights with the National Human Rights Commission. Thank you.
Thank you so much, Aniti. Next up, I would like to invite the beautiful Rita Gatwani from Women in Response to HIV, AIDS, and Drug Addiction in Kenya.
Hi. Good morning, fellow criminals. It's nice. Yeah, it's nice to see you all. I must apologize for missing the first few presentations. I'm sure they were wonderful. So I really do not like slides. So what I did was just put some pictures together and we can just talk about what the spirit of the movement has been for women who use drugs in Kenya. Which button is the clicking? This one. Okay, so this is, okay. So this is where we started. If you look, you'll just see despondent-looking ladies, very sad about life. Not because we were using drugs. I mean, we were enjoying the drug use bit of it. But the fact that there were no services, there were no health services, there was no OAT, there was NSP, but insufficient. So this is us. On the first day, we went to register at the first OAT clinic in Kenya. And we just sat on the bench wondering what next. And then we started to informally organize. We were hosted at the biggest mental health hospital in Kenya. That's where the first clinic was. And we just started to, sit under the bridge, smoke cigarettes, cross the road dangerously, and organize. We even tried going to church. When you're at that point of, I don't like the word recovery, but when you're at that point of wanting to move from a problematic place, sorry. Oh, okay. Then you do anything possible. So we went to church. As you can see, the ladies are always in the corner. This is me, just always on the sidelines for a very long time. And then we began to sort of see ourselves separately as women who use drugs. And we began to find our own little smoking corners and our own little, places within the male drug-using scene in the clinic. This is just us. We had a very nice hospital, actually. Monkeys would come. We had a big park. We had lots of wellness type spaces. So we would take our methadone and then sit and feed the monkeys, and that was a really big part of our wellness. Again, we have always been who we are, and unfortunately this has meant stigma has followed us, keeps following us, but this is who we are. I mean, we are fun, we are quirky, we have personality, and we don't shy away from that. And then we slowly began to think of how to bring back some sort of dignity into the life that we were living. And so we started fundraising locally to distribute sanitary materials and SRH materials. We started partnering with people to bring back some sort of dignity, even just water, right? Because most of our women who use drugs live in areas like these. So bringing clean water, food, things that would be taken for granted, but things that really, we lost 2 of these women. This is a difficult one. In that time, we sensitized police. We have done paralegal work representing our people in the courts. We have worked with universities. This is at the Nairobi University, where we participated in developing a student app on drug use and mental health. We have done a lot of artwork around Nairobi city. This is something that some of our community members drew, and I just felt really cool standing up against that wall, you know. And we formed a network of women who use drugs. We got to a point where we decided we need to form a national network of women who use drugs because our issues were just always underrepresented. So we formed this network. We shot a documentary on women who use drugs, which is really nice and available on all our platforms. We've lost many people, as have we all, as has everybody in the drug user movement, and we've also welcomed lots of new life into our spaces. It's really bittersweet, you know. We've mobilized women who use drugs in Zanzibar. This is with Kasim from Tanpud. This is Zanzibar as well, where we were mobilizing women who use drugs to organize. This is Uganda. As you can see, all the women who use drugs are just fire. Yeah. In Uganda, actually, everybody's a dancehall artist, just so you know. We have participated, this is during workshop to develop the first ever shadow report by people who use drugs to the Universal Periodic Review of the United Nations. So we always have fun during our gatherings. Yes, we are learning. Yes, we are writing reports to the UN, which is big. But we also make sure we connect in every space that we go to. This is another training. We've trained drug user groups in Kenya on the Global Fund processes. We have engaged with members of parliament. This is the Parliament of Kenya at a point where we were trying to get needles and syringes decriminalized, which effort finally bore fruit, and NSP was decriminalized in Kenya in 2022. This is, you know, just a picture with the MPs. We have engaged in media advocacy to get the law changed around NSP as well. We have been fortunate enough to participate in conferences and represent the issues of women who use drugs and people who use drugs generally. We have participated in global advocacy projects for young women. We have, can you see yourself, Robert? So we have had a chance to meet wonderful women who use drugs from around the world. Angie, I just couldn't find a picture of you. But if you can tell, some people from Input are in this picture. And this is Bangkok during an Input board meeting. So we've had the opportunity to go from a small grassroots group in Kenya to mingling with women who use drugs from around the world and being able to strategize together and also have some tequila. It's been great. We've spoken at the United Nations as well. Violet. We've spoken at the United Nations as well, presenting the issues of people who use drugs in Kenya. We have managed, and this is something that I'm really proud of, to bring more women who use drugs from Africa into the space. Previously, the space has been very gate-kept. It's been the same people going for conferences, but finally we are beginning to see new voices. We won't be here forever, so it's really nice to have more people, and they are here with us somewhere in the room. And this is just us being us. We have formed a sisterhood. We formed a space where we are free to be ourselves. We are free to speak. We have the courage to speak. And we know we have support from the rest of the global community. And here we are yesterday, just to show where we came from. Remember sitting at that clinic very sad. And here we are in Book-Up after a wonderful workshop yesterday. And we are here, we are unshaken, and we are unbowed. Thank you.
Thank you, Rita. Robin, you can get your revenge at some point. Don't worry. And now, last but not least, another absolutely powerful, incredible woman will close off this session for us. Tanya, where are you? Woo-woo! Tanya is from Lace Boots Initiative for women who use drugs in Zimbabwe. Over to you.
Good morning. My name is Tanya. You can call me Skara because we are all drug users, unless you're not a drug user, but I'm joking. So I'm from Lacebut Initiative for Women Who Use Drugs, and most of the work that we've been doing is mainly supporting Zimbabwean women, youth, and gender diverse people who use drugs. So our mission as Lacebut is to empower, mostly to empower people who use drugs so that they know their rights, you know, and are able to, they're able to, you know, to fight for their rights. And then most of our work is, please forgive me, my glasses have expired, so I really need to like be right by the screen. Forgive me. If someone can help me buy new glasses, I'd really appreciate that because I'm blind folk walking. So yeah. Okay, so now it's better. So mostly we do information dissemination at grassroots level. Particularly we teach on harm reduction, how to reduce harm, the classification of the drugs that are available. And we also do provide safe sex commodities by distributing condoms, lubrication, and other essential items that we can get our hands on. Currently, globally, there is a shortage because of the whole, you know, thing that happened with USAID, and most of the places where we were referring our drug users were places mainly for other KPs because we do not have a designated like health service that are mainly for drug users. So we were poaching where sex workers go, where the LGBTQI goes at PSH with the colors that they were using. So that's where we were basically accessing services. Right now, we providing research and referrals. Firstly, we identify accessible health services and also do referrals for support, for psychosocial support, as well as in peer-led support at community level. And then we also do capacity building in the communities where we just sit and literally just talk about different things in relation to harm reduction, such as overdose prevention and mental health support. And we've been collaborating with some amazing organizations in our country. In our city. Lacebut is based in the city of Kings and Queens in Bulawayo. So we've been working with a couple of organizations that are either serving the KPs or that are just interested in partnering with drug users. So most of our projects, we've been active for 1 year. Sorry, I forgot to mention. We've been active for about 1 year, and these are the projects and activities that we've managed to do. So we did, our first project was implemented by Youth Raise International, and this is an activity this is a project that was implemented in 8 countries: Nigeria, Ghana, South Africa, Tanzania, Uganda, and Zimbabwe, and Bangladesh, and Kyrgyzstan. I said it correct. So the main purpose of this project was to generate evidence on how, you know, youth are engaging with the Global Fund and how they can, if they're found at the decision tables where, you know, when it comes to creating activities and etc. about the youth. So our communications officer, Ms. Juliana Shogo, was one of the 3 young KPs who were trained on this, who were part of this project rather. And currently she's part of the international working group members of Youth Raise. So what she does is just coordinate activities that are for youth And this project was for young people who use drugs between the ages of 18 and 30. So then under this project, we then got an assignment for small grants, and the young KPs chose to do a photo voice project, calling it Voices of Resilience. And they mobilized, they organized everything, and all we did at least was just provide support and just direction. But most of the activities they coordinated by themselves. And then during the 16 days of activism, through a small grant that we got from the African Network of People Who Use Drugs, we managed to organize a one-day workshop, and we also invited a police officer from the Zimbabwe Republic Police Victim-Friendly Unit just to help us understand how to go about reporting issues when it comes to intimate partner violence. Because as women who use drugs, sometimes it's hard to reach out, because there are things like when you go to the police station, first you need to pass by the charge office desk, and sometimes it's none of their business, but then you end up just telling them. So most of the times it's like it discourages us from going. But because of the information we got from Constable Shangwa, the police officer who joined us, we now know that we're not supposed to just start by disclosing our case at the front desk, and that we're supposed to just ask for the victim-friendly unit. So this was just some of the stuff that we did. And then we also, International Day of Drug Users. International Day of People Who Use Drugs. Last year we participated. We got to have a small commemoration through a small grant that we got from the International Network of People Who Use Drugs to have we called it a chill out. It may have gone south because when we initially planned it, we were supposed to go for different activities just to bond as drug users. But then there was a thing that happened with the police, and we had to cancel. So this is just, not cancel as such, we had to find a secluded place where we could be safe. So these are just pictures of the photo voice project, and our communications officer managed to attend the youth-led organizations engagement, which was done in Joburg in May. And she's learning a lot, and she's really pushing for a young woman who uses drugs. Then these are just our photo voice project participants. Then we also have last year's International Drug Users Day, and then at the bottom there, that's during the workshop for 16 days of activism. Then at the other bottom there, that's just our Waterford support group. And above there with the Russians and the Smausu there, that's our communications officer, Juliana. So because of the work that she's been doing, she's also managed to submit a personal business proposal away from the organization. So now she runs, this is how she does the support group in her area, by just having customers come through and talk, because she was like, in her hood, we can't do the same setup because drug users are coming from different backgrounds. Then we also managed to submit a shadow report through the assistance of input with support from Love Alliance. So our report was highlighting just some of the issues that need to be addressed by our Zimbabwean government, because there was a list of state issues that they presented to the UN, and we also decided to do a counter report, because nothing is really happening on the ground. They say that there's harm reduction services available in the country, but it's just one organization that barely works with drug users that is providing the NSP, and they don't even know how to roll it out. I'm not going to say their name for my own safety. Yeah, and future purposes, maybe they know someone who might give us a donation. Yeah. So there's some issues that have been happening in our country. I'm not going to touch on them, just a few statistics. This is what's been happening with the young people. There's a rise in drug use. If you compare the years from 2023 to 2025, you find that most of there's literally no harm reduction center. If you're a drug user, in Zimbabwe, if you are going out for help, the moment you come out, it's like you are referred to a rehabilitation. So we might have the multi-sectoral, the multi-sectoral drug and substance abuse plan that exists, but it's not really rolled out. And in this one, this time around, this one replaced the one that we had from 2020 to 2025. So it's now from 2024 to 2030. It doesn't even define what harm reduction is. It just throws us into the same basket with treatment and rehabilitation because it's something that's being conducted by the Ministry of Health. And then these are just some 4 stories that I wanted to highlight of some law reforms that have been done. They now do naming and shaming of people who are found in possession of drugs, and so there's some unfairness in all of this, like the issue at the bottom there with the Chinese who were found dealing cocaine that was worth about $1.7 million US, but they only got away with what we refer to as a slap on the wrist by just paying $150 fine and then being deported. Whilst we've got this kid here in yellow, he's called Ras Pompi. He does dancehall music, some nice vibes. So he grew up in the music scene. Now he's a young man. And because of the economic difficulties, I believe that's why he was doing what he was doing. But he was found in possession of marijuana and just Bronclear. Bronclear is like that Benlin for flu item. So it's unfair in the fact that 1.7 million cocaine, a hard drug, as compared to what Raspompi did. So he's been sentenced to 6 months in jail. He's currently serving. There are videos of him also circulating online while he's serving his jail sentence. Then there's a case of 2 sisters from Kuwadzana, where the marijuana is there. They were arrested after being found in possession of, I think, about 60 kilograms of marijuana. These women have been sentenced to 3 years in jail. And then there's also the case of our former late president, Robert Mugabe Jr. Robert Mugabe, his son, Robert Mugabe Jr., was recently found in possession of cocaine and cannabis in his car, and he got arrested after trying to run away from, just trying to evade the police. So these are just unfair terms that are there in our country currently. And there is our multi-sectoral drug and substance abuse plan, which was launched last year on Global Day of Action. For the first time, it was held at the State House and launched by the president. So there's a lot that's going on, and there's some current law reforms that have been done. You can see that there's now mandatory sentencing of between 15 to 20 years in prison for level 14 aggravating circumstances when, and even more years if you're found, with severe consequences. And then there's also penalties for possession. For cannabis, they've said up to 10 years for imprisonment, which can be adjusted depending on the quantity that you've been found with. And then crystal meth was like a drug. Yeah, we knew crystal meth was a drug in Zimbabwe, but it was not appearing on the Dangerous Drug Act. So this last year, discussion started, and now crystal meth is actually classified as a dangerous drug in Zimbabwe. Then we have a new anti-drug agency that was approved this year, and they are the ones who are also pushing for those punitive laws, and instead of really trying to understand what harm reduction really is. And we rarely meet with those people, and to be honest, it's scary in our country right now because I'm also one of the people who are on the watch list for the government, and in as much as we are working as lazy, but we are not registered, but I would rather get arrested for doing right work rather than just keeping quiet and not doing anything. Yeah. So our call to action is we urge the government of Zimbabwe to prioritize public health and human rights in drugs, in its drug policy by reviewing and fairly reforming laws and policies that criminalize people who use drugs. Also ensuring equitable access to harm reduction services like needles and syringe, and making sure that opiate agonist therapy is not only available in rehabilitation centers as a way of detoxifying opioid users while they're in rehab. Apparently, you need to get a prescription that is signed by the Medical and Dental Association of Zimbabwe for you to get methadone when you're in our country. And naloxone is barely available. Yeah. And also by addressing human right violations, including violence, abuse, and torture against people who use drugs. Sometimes we're beaten up, especially the young men. This is why at Lacebrook, instead of, I know we are meant to just be working with women, but as women, we are mothers and sisters, so we could not leave the brothers, and we decided to also bring in the young men between the ages of 18 to 30, and probably just, I don't know, we'll find something to empower them with in the future, and hopefully they can also start a youth-led initiative separate from us women. Yeah. So lastly, I would like to say that harm reduction is about saving lives, not enabling drug use. Thank you.
Thank you so much, Tanya. And thank you to all of our incredible speakers. It is so wonderful to be able to showcase the work being done by us as people use drugs-led networks across the region. And this is just a tip of the iceberg. If it was up to us, we would have taken over the whole day. But we also want to be able to share other incredible work and information. And with that said, I would like to invite our next speakers to come join on the stage. There are enough of you here. There's less of you, so you can also hear. While we say that, this session we're going to be talking about mental health and stimulants, expanding stimulant treatment models in different regions. So Natalie, you're back up. Sean Shelley, Matt Southwell, Shanae Roberts, the beautiful Sarah Whipple. And unfortunately, Ernesto was not able to join us due to issues that arose. So we will be helping him out in support and in thought. So with that, over to lovely Natalie again. Thank you all.
Hi, everybody, again. Okay, so today's topic... No, you're not in my chair. Okay, so today's topic is about mental health and stimulants, expanding stimulant treatment modules in different regions. So initially we were supposed to have 5 speakers, but unfortunately Ernesto Cortes wasn't able to meet his flight, so he's unable to attend. Our first speaker is Mr. Sean Shelley. So Mr. Sean Shelley brings academic, programmatic, research, clinical, and lived experience together to create a 360-degree view of drugs and people who use them. He founded the South African Network of People Who Use Drugs, SAMPUT, and the South African Drug Policy Week, and has published more than 30 peer-reviewed articles and book chapters. So Mr. Shelley will be speaking about the intersection of stimulant use and mental health, which will addressing trauma, depression, and anxiety, issues with attention deficit hyperactivity disorder, and the use of stimulants. Okay, our second speaker is Mr. Matt Southwell from the United Kingdom. He will be talking on expanding stimulant treatment models, different examples on pioneering community practice and stimulants. And Matt Southwell was one of the founders of the Crack Squad in East London in the 1990s, and in 2018 led a group of peer experts on stimulants to research and write the UN Technical Guide on Stimulants and HIV. Okay, and our third speaker is Shanae Roberts, which is from South Africa. She will be speaking on community-led approaches, stories from people with lived experience, centering community voices in designing stimulant treatment. Shanae is the National Advocacy Coordinator at the South African Network of People Who Use Drugs, which is SAMPUD. A passionate human rights and harm reduction advocate, Shanae works to amplify the voices of people who use drugs, ensuring they are not just heard, but meaningfully included in shaping the policies that affect their lives. She is especially committed to advancing the rights of women who use drugs, challenging gender-based violence, and fighting the stigma and discrimination that fuels exclusion. Through the leadership, Shanae has helped build grassroots advocacy networks across South Africa, empowering communities with the tools, knowledge, and platforms to advocate for the health, dignity, and justice. Her work is grounded in the belief that nothing about us should be without us. Okay, and then our fourth speaker was Sarah Whipple from the United States. She will be speaking on practical harm reduction tips for methamphetamine use, day-to-day harm reduction tips. And then Sarah is the Community Engagement Coordinator of the TUE Harm Reduction Collective, an organization providing syringe services, smoking supplies, naloxone opiate agonist therapy navigation, harm reduction vending machines, and drug checking in rural Northern California, USA. She is also a community organizer for the Sacramento Sex Workers Outreach Project and a steering committee member of the California Syringe Exchange Program Network. In 2024, Sarah received the Jude Bryan Emerging Female Leader Award from Input and Insight. So further ado, we'll give the floor to Mr. Sean Shelley.
It's amazing what AI can do. I'm supposed to be remote. This is just an avatar. Not really. I'm paranoid that my computer is going to switch off halfway through, so I've got my cell phone as backup. But if I stare at my cell phone while talking, it's not great. All right. So today we're talking about stimulants and mental health. I've taken the liberty of shorting stimulants to methamphetamine, basically, because meth is now the most commonly used stimulant in South Africa. You know, crack just leaves you wanting more crack, and cocaine is just unaffordable. So everybody's using meth because they feel motivated on it, and it's really taken over here, and there's a big supply. And we have great meth in this country at very cheap prices. It also has 5 mechanisms working on the dopamine system in the brain. So it's the most intense form of boosting this thing called dopamine, and we've all heard the pro-dopamine and anti-dopamine models. It's not all about dopamine, but with methamphetamine, it is pretty much a lot to do with dopamine as well. So in the Western Cape, we call methamphetamine work because it is motivating. So, you know, have you got any work for me, whatever, you know. So a lot of people are permanently employed here because they all have work. And so the common narrative around meth, and I've heard this from a lot of people, and to use a colloquial and fairly derogative term, they call it, oh, you're going to become a tick monster, because they call methamphetamine, you see a tick, you know, because of the cracking sound it makes in the lolly. But people think it's purely destructive, and I've seen a lot of stigma towards it, even amongst drug users. But like most stimulants, its effects are very heavily dose-dependent. And it depends on the delivery and the interaction between, you know, the individual, and all of us are different, so we have different reactions to it. So I want to show how dopamine, trauma, and exhaustion interact to create either focus or psychosis. It's a nice alliteration, focus or psychosis. Anyway, so understanding this and not fear-based stuff is where we start with harm reduction around this. I presume this is my, yep. Okay, so with the brain and methamphetamine use, we kind of get this cycle that's going around. You don't know whether it's the chicken or the egg. Did the trauma lead to the methamphetamine use? Does the methamphetamine use lead to increased trauma? It's a difficult thing to really talk about with any certainty. And what I'm going to highlight in this presentation is that we have a lot of misinformation that's out there and contradictory information, which I'll talk about a little bit later. So I want to talk about trauma and mental health. And people think that, if you've had a traumatic childhood, you should just get over it. And I heard a great example the other day. There was a comedian who was saying, we expect people to overcome their trauma. However, would you like to stay on the 36th floor, he was 36 years old, of a building that's been built on an unstable foundation? And that really rang true with me, We need to stabilize our foundations, which is often ignored by people. So people try to stabilize in many ways. If they're lucky, they will find people and perhaps partners who can give them the love and support to help stabilize their foundations. They can find a good therapist, okay, as well sometimes. They can find practices like meditation that might work for them. These don't work for everybody, but they might work for this particular person. Others become obsessed with money, power, and develop personality disorders to mask this instability and just become total narcissists or sociopaths. And others use drugs, whether they are pharmaceutical drugs or whether they are unregistered or unregulated drugs. So often the drugs help, but when you get the drugs wrong, whether you're a doctor prescribing or you're an individual using, they can also cause a problem. So I have no particular position on this because we're all different. So with dopamine, it's quite interesting. There's this inverted U curve. So what happens is if you take too little and have too little dopamine and you take too little of the medication, you feel actually fatigue and apathy. In the middle, you've got that focus, and on the other end, you've got the kind of paranoia. So there are these optimal levels that you've got, and you get sort of therapeutic versus non-therapeutic doses. So here's some example of some dosing schedules. But what we must remember is I can't remember what year it was, but the United States Attorney General released a report calling methamphetamine the most evil drug known to man. And at the same time, the US Navy released a report saying how methamphetamine, and this was actually methamphetamine, not another sort of amphetamine, was a lifesaver and enabled long-term missions, flight missions, and lowered impulsivity amongst pilots and helped them operate despite sleep deprivation. So you've got these two stories about the same thing, which are very different. It's when it's being prescribed and then all of a sudden it's very good, and on the other side it's it's bad and evil, and we have this contradiction when people talk about dopamine. You've got some people saying, oh, this is how you boost your dopamine naturally, etc., and these ones saying this is how you go on a dopamine diet. It's the kind of neurotransmitter of the moment. It's probably got a TikTok channel or something like that, because it's really promoting itself a lot. So one of the big pieces of misinformation is around psychosis and methamphetamine use. So the methamphetamine can contribute, because it's got dopamine, to some mental health issues, but really your biggest problem is sleep. Okay. So So if you just take sleep away from somebody, whether they're on drugs or not, they are actually going to have a lot of psychotic symptoms eventually. So after 108 hours, they've got full psychosis, most people. This is obviously a continuum. These aren't hard, fast things. At this hour, you suddenly become psychotic or whatever. And in fact, what you see is people using methamphetamine, in the early stages, it boosts their sleep deprivation and puts their performance back on normal level. So it usually takes a bit longer. But we all know that a lot, if people use a lot of meth, they end up, what? Who's calling me? Who said that? Who called my name? What's that shadow over there? They become a bit paranoid. And that's because that dopamine is going in, being exaggerated in certain parts of the brain. It's interesting that actually that anxiety and excitement are exactly the same thing. It's just the pathway for dopamine and how we remember previous experiences that determine whether we feel excited or whether we feel anxious. And so if you haven't coached yourself into understanding that the anxious feeling is perfectly natural, you do tend to become more anxious, and it becomes a paranoid cycle. And then you see people taking more and more and standing at the door or the windows, looking out the blinds, scared of what's there. You can't talk about methamphetamine and mental health without talking about ADHD. Now, here's an amazing thing. So, a lot of people will self-medicate for ADHD with methamphetamine, okay? You go to the United States, and I had some methylphenidate with me when I was in Atlanta there. And there were a lot of people using meth, and they all wanted to get my methylphenidate. And I said, well, you've got meth, why would you want the methylphenidate? They said, no, well, because we actually prefer it, and it controls our symptoms better. Great. So why don't you go to the doctor and get it? Because the first line on the package insert is, do not prescribe to somebody who has a stimulant use disorder. Now, that is absolutely mental. In the Netherlands, that's the first line, right? And it's perhaps interesting to know that stimulants are a very prescribed drug in the United States, and yet everybody's saying there's no medication for harm reduction for stimulants, but if you took away all those stimulants, I guarantee you a lot of people will be looking for methamphetamine on the street. Okay? And then suddenly you will have replacement therapy. So consider this. So I go to the doctor and he asks me how my prescription stimulants are going. I say, it's fantastic. I'm taking 2, 3 a day, depending if it's short or long acting. And it's really good, and I'm stable, and I'm able to concentrate and everything. Fantastic. That's good. Next month I come and I say, you know what, I've decided to do it differently. I'm taking all my medication, I'm saving it up till the end of the month. And then I'm going to our partying, and I'm taking it all, and I'm getting really high. He's not going to be too happy. But if I come along and I say, every single day I take 10 milligrams of methamphetamine regularly, just to control it. If you do any assessment, it tells you you are fully dependent on the drug and you need treatment. Okay? But if you say, I go once a month, buy 2 grams, and party the whole weekend, you're only moderate risk. These are 2 totally different stories for exactly the same thing, basically. So we've got a lot of these contradictions that we see, and Carl Hart did a fantastic review of the paper, showing how people say, oh, well, methamphetamine causes all these problems and cognitive inabilities and that, but it depends on the dose. The problem is that when you're using an unregulated drug, it's difficult to know the dose. If you're using methamphetamine that comes from Afghanistan, it's got double the potency of the methamphetamine that is synthetically made in this country. It's difficult to know that until you actually take it. But we are people of habits, creatures of habits, and so we tend to take the same amount, even though it's got a different strength to it. And because there's so little drug testing, we don't know what's in it. Fortunately, in South Africa, we have very pure methamphetamine. It's cut with MSM, which even the DEA say is not harmful to you. So if they're saying that, it's probably good for you somewhere. Yeah, interesting group. So we've got to remember that when it comes to methamphetamine, there's all these narratives, some of which are true, some of which aren't true. Some of them are only true when you're taking huge doses, all right? We've got the story that it causes psychosis, when really that's more of a sleep thing than a methamphetamine-specific thing, although obviously dopamine can contribute to some mental health issues and that. The one thing to me that's very, very important is the kind of, where did I put that controller now? This is ADHD. Where did I put the button to control that? Okay, in my pocket. Drug set and setting. Critically important in any drug. And this is where harm reduction really begins, because you can change any one of those aspects to alter the effect of the drug. So there's no predictable chemical cascade when you take a drug, no matter what drug it is. If you take So my doctor gave me an example. There's an antihistamine which is supposed to not cross the blood-brain barrier, and you're supposed to be able to take it, and it's supposed to not make you go to sleep. He's one in 15,000 people who, when he takes it, he goes straight to sleep, and he can go into a coma. In fact, it's quite dangerous for people that this happens in, because he has a totally different response to it. Because for some reason, it's crossing his blood-brain barrier, whereas 15,000 people it doesn't, he's the one that does. So we can't go and say this is all the same thing. And I found it amazing when there was this report of alpha MVP being in South Africa, you know, the zombie drug kind of thing. And I got a call from a doctor in the emergency room at Steve Biko Hospital saying these guys have come in and they said that they've taken this and they're going absolutely crazy and they can't control themselves. And I said, look, first of all, the drug's not available in the country. They've taken methamphetamine. This is what's happening. Just tell them it's going to be okay, you know, calm it down. And bang, well, actually, we've got to just make up a story. We've gone and tested it, and it's not that, it's just methamphetamine, which you've had before, and boom, guy's calm. Your mind is an incredible thing when it comes to this. You know, we see people saying, oh, I can take the blood from this person in a syringe, and I can inject it into me, and I can get high from the residual heroin in that. Not true at all. I mean, you do the calculation, it's impossible. But they believe the best high I've ever had. So you have to discount these absolute narratives that are just false. So drug setting, we've got to look at all of this. And trauma has an incredible impact on people. It makes them very reliant on whatever they need to rely on. We know that you 14,000 times, I think it's 8,700 times more likely to inject heroin if you've had more than 7 adverse childhood events. Amongst one population study that they did in the United States. Fortunately, that's the only place that got them. All right, so I don't want to go into your talk. I'm just going to talk very briefly about, I'm sorry about this. Okay, sleep regular, I was working with a forensic population, essentially, a gang population in Lavender Hill in Cape Town, which is kind of a place where there's no lavender, put it that way. It's like Skinner boxes for people. So here were these people coming, they were all going, every now and then they were going psychotic and going into hospital. I said, just sleep regularly. Eat and hydrate, protein in particular. Space your doses. You know, calm environments. Talk to people. And when you're not using meth, think about what the possible consequences could be, you know. Think about what does that psychosis look like. Because when you know that it's not actually somebody behind the curtain calling you before, and you train yourself to understand that, you come to a stage where you don't necessarily become psychotic. You must also remember in South Africa, for people who've got no place to rest, 72-hour observation is an incredibly comforting place. So we're seeing people increasingly learn psychosis in order to get support. All right? So it's pretty sad. And teach yourself how to deal with psychosis. We don't have time for that now, but there are definite techniques. Don't say to the person, I'll call your mother, because that's one of the reasons why they're psychotic. You know, you've got to know who you're talking about. You know, I love this reconciliation with the family that destroyed you. Anyway, so you've got to decide for yourself, are you going for balance or are you going for abstinence? If you're going for balance, be aware of your dose. Be aware of what makes you feel good. And frankly, meth is not a great drug to get high on. It's a drug to get motivated on. It's a drug to feel like you can do something and achieve things. But get up and do it, you know. The same molecule that sharpens focus can, in excess, fracture reality. Our goal is to understand that there's a threshold that can help us. And so instead of telling people just to stop, because you get this terrible anhedonia afterwards, and remember, they're medicating something. So deal with that thing. I always say, never go to a specialist addiction psychiatrist or psychologist. Go to a psychologist who's going to deal with the problems, all right? And the drugs are the solutions. They're not usually the problems. And when you can start making conscious decisions around your drug use, it very seldom becomes really problematic. The aim isn't to stop people from using drugs. It's to stop drugs from destroying people. Yeah, it is. The fact of the world is, some people do better on drugs, and we need to get the fuck over it. Thank you.
you so much, Mr. Shelley. So our next speaker will be Matt Southwell. Thank you.
Cool. Okay, apologies. Oh my gosh. Hello. Okay, there we go. So apologies, I don't have a slide presentation, so competing pressures of work, but let me take you through some issues looking around the treatment of stimulant use. What the professionals would call stimulant use disorder, I think it's a really unhelpful term. I think stimulant use condition or drug use condition, and one of the things I think we should lobby for in the next round of WHO guidelines is to get rid of this really toxic terminology around people who have struggles with drug use at certain points in their lives. So I think, so in the way that Sean has grounded his speech in methamphetamine, I'm going to ground my speech in crack because that's the community I come from. And I will make similar references around, for me, being a short-acting stimulant user. And if you look at someone like Sean, who is someone with ADHD, for whom methamphetamine calms him, anybody who knows me knows I'm a reasonably speedy person. Methamphetamine makes me unbearable. Let me tell you. I mean, I will never take methamphetamine again, partly for my own protection, but mostly for everybody else's protection. It's really not a pleasant experience. So I think it really highlights that issue of sex. No, we are different people. We have different neurotransmitters. We have different ways that our systems are wired. And one of the challenges of being human is to learn how to manage our internal system. Now, if you start to learn that you're carrying different scripts from your parents, you're carrying different trauma, you're carrying different issues through your life. And let's be clear, trauma doesn't mean that we all go on to experience PTSD. Many people go through lots of trauma and are highly resilient, and sometimes our drug use is what helps us be resilient to that trauma. And I think I listened to an amazing Dutch psychiatrist who said, why are we so worried about letting people have the medications they need to manage their trauma, particularly as we don't have the capacity to respond to lifelong psychotherapy for lots of people? Now, why do we have such a problem that people use medication to manage and help them find balance in the world? So the story for me with crack started, I was a dance drug user who took cocaine and then at a certain point went to the Netherlands where there was this Dutch Surinamese population, a migrant population who were heavily involved in smoking cocaine and also selling cocaine. And they set the culture of how cocaine was used. And we went across with a friend who was an injecting heroin user and he was an injecting everything user. He was in a lot of challenges. And he had been recently diagnosed with HIV. And we went across and met this sort of older generation of crack users or free-base cocaine users really in the Netherlands. And they had this pattern where they smoked, so you washed up cocaine, so you free-based it with ammonia, and you do it in a group setting, so you tend to have 4 or 5 of you using together. We smoked it on silver foil, so it's a much lower dose method, so not this surging effect of piping, but a slower building effect, so more like snorting in terms of its dosing range, but it was a smoking effect. I have a dust allergy, so I struggle to take drugs up my nose, so for me smoking was a different route, but I was also aware that high dose was a potential problem. And what these Dutch drug users taught us was that cocaine's quite a challenging drug to manage because it doesn't really have an ending to it. You can carry on using and using and using. And what they taught us was that we started off smoking cocaine, or freebase. You freebased it in spoons, so you'd make maybe a dose that could go around the room about 3 or 4 times. You'd start off smoking cocaine. As your adrenaline levels picked up, you'd then start to add heroin, brown Afghan heroin, and then the session would end by just smoking heroin. So by using the 2 drugs together, we were always what we call brown and white users. We managed to bring that beginning, middle and end into the process by using different drugs. Also, because the foil passed around the room, it also helped you drop your adrenaline levels because just a natural pattern of waiting for the foil to come back to you meant you weren't in these high surging doses and you also then let your adrenaline drop back down again, and then you calmed, and then you go back into your next dose, and the foil would tend to go recircle different ways around the room. So for me, and also if you're a cocaine user, you tend to be quite obsessive about things. So we were very obsessive about being in control of our cocaine. No, for us, the Dutch had this beautiful campaign which was be the boss of your base. And we had this idea that, no, we bossed our base around, we didn't get bossed around by our base. And honestly, we thought cocaine snorters were a bit lightweight. You know, we were proper cocaine users. We didn't see ourselves as like this lesser form of cocaine users. We thought we were, no, you just stick it up your nose, but we know how to freebase it. You know, it's like, no, we are pretty skilled at this shit. So then suddenly we hear this new, so the cocaine is new, the freebase, this is the beginning of the crack era in the 1980s. The Drug Enforcement Agency come across from the United States and say, watch out UK, this new crack demon drug is coming, it's going to destroy you all. And so the Metropolitan Police set up in response this crack squad. Oh, bugger. No, I haven't even got past the first point. Okay, and then, so we set up this, the police set up this thing called the crack squad. They came and saw us. They basically went away. We took their name and became the crack squad instead of them because we thought it was a really good name. And we have a logo which was a bit like the NYPD badge. It was the crack squad protecting the crack using community from within. And we sort of just really challenged this concept that crack couldn't be controlled. We said, look, if you go around telling everybody that crack is something that cannot be controlled, that becomes the reality. And also, if criminalisation always pushes people towards high-dose using because people have to use fast, no, what allowed the Dutch system to operate was the police agreeing to back off drug dealers, and if you didn't cause any problems with your neighbours, the police wouldn't come through the door. That allowed all the Surinamese drug dealers to allow people to smoke heroin and crack in their houses. That allowed smoking to become dominant, which is why now the Netherlands has 10% of people injecting and 90% of people not injecting. Now, is that good or bad? Not necessarily. It's just a cultural trend, but it shows how allowing people to manage their supply allows people to teach self-control to each other. Now, in the side event that we have on stimulants, which is where you can actually come and hear the topic I'm actually meant to be talking about, we will have some amazing people talking about the future of pharmacotherapies with stimulant users. People using, yes, all the opioid, all the stimulant agonists, but also new drugs, psychedelic mushrooms, MDMA, ketamine, and even a new naloxone for stimulant users, some drug that binds to the stimulant receptor and draws it out of the brain. So look, there are lots of resources. We went on to work with the Royal College of General Practice in the UK, and we designed the UK's response to crack between crack users and the GPs. They were so much easier to work with, and I don't mean to be rude to my psychiatry friends in the room, but working with psychiatrists still ended up pathologising us. GPs saw us in a rounded health position, and we developed this wonderful tool with them called the 8-point health crack check, where we just broke down the issues that people who use crack face, so lung health, sexual health, mental health, all of these issues, and then doctors knew what to do with it. When you said, look after these crack users, the GPs got completely freaked out. When you said to them, could you meet this person and talk to them about their lung health, mental health, sexual health, they went, oh yeah, we know how to do that. And it built relationships. So I think the key for me, I think, is with these drugs is treatment starts with empowering people to take control of their drug use from the start. Some people will choose that stimulant use just becomes too much fucking hard work, and you just don't want to. You might be in control, but the control takes just so much work you just get bored of it. And fair enough, and then abstinence is a very effective form of control. But for those of us who choose to actively use drugs, then I think understanding that self-control is a key part of that regulation. There are new treatment options that will help us make more changes, and we need to advocate for those. But no treatment option is going to be effective if it's not framed within a humane treatment system that empowers people.
Okay. Thank you, Mr. Metz-Southwell. So our next speaker is Shanae Roberts, and she will...
Yeah. Okay. So, it's loud. So, hi everybody. So today's video is about community-led approaches for stimulant use. Support shaped by people with real-life experiences. We know stimulants looks different to everyone. Some people want harm reduction, tools safe for kids, others want access to treatment to stop using altogether, and others want information about the drugs and negative consequences before they make choices about using the drug. There is no one-size-fits-all solution, and that is the point. So the video that I'll be sharing, it's a video that centers around the voices of people who use stimulants, because too often they aren't asked what support they actually need. It can be hard to name what's needed because of stigma, lack of information, or no services that reflect their reality. Harm reduction is often designed for opioid use, and this leaves stimulant users left out of the conversation. So today we're going to hear stories and ideas, and not as an instruction, please. But before starting the video, I would like you to think about what can you relate to, what surprised you, and what support should exist in the community for stimulant users. Please share my video.
Okay, my name is Michelle Marais. I've been a substance user for many years. I have used crystal before, crystal and crack cocaine, which is a stimulant. Mostly for its stimulating properties. It's an upper, gives you energy, especially if you have to work, and also people tend to use it for substitution if you've been on other drugs like heroin and you're looking for something else. The disadvantages, it causes anxiety, paranoia, psychosis, which I think psychosis is a very big, the biggest driving factor for people using crystal, because they tend to get into a state of mind when you use crystal, and it's just a crazy loop which you continue to.
Okay, Michelle, so let's say you get help. What kind of help would you want?
Okay, so because it's crystal and it's in a different class of drugs, opiate substitution therapy or harm reduction measures, yes, but more for crystal, it would mean abstinence programs or abstinence type of approach to getting away from your drug of choice. I know that it's not really a harm reduction; it's still harm reduction centered, but crystal. The only thing that works for crystal is abstinence.
Okay. Thank you so much for talking to me, Michelle.
Myself and what I personally think, or for anybody else in my situation, if I had to be like I am, I'm looking for help because I'm at a point where I've never been before. And drugs just takes you on a roller coaster, downhill, not uphill. So, and if you are fortunate to realize that and you want help, and I think for those of you who do, I would personally say, then I would like to get like the help of social development where they can, empower me or help me to get back to where I was, to help me to integrate into society, to become the person that I was, and that kind of thing. So, programs like harm reduction, TB, HIV, the methadone program are fantastic, and the other programs that they have, the needle and syringe program, programs like that, where they empower you, encourage you, motivate you, or especially with regards to the methadone, which weans you off the drugs. There are also programs like that helps you develop your skills.
Hello everyone, my name is Betty. I'm from Soshanguve. The drug that I was using is crystal meth. The disadvantage of the drugs is that they make me have sleepless night, and in the morning of the drugs is that they make me have sleepless night, and in the morning when I wake up, I feel tired. I also have back pain. The advantage is that they make me feel so excited, and I was so high out of this world.
And Betsy, can you tell me, if you were to get help, like what kind of help, what would the help entail for you?
The help that I would get, I would love to go to rehab so I can stop smoking.
Thank you, Betsy.
Thank you.
Ayanda wabambatha ngila eThekwini eGreyville mina i-drug choice yami i-rock mfethu. I-rock yangenza ukuthi ngibe hyper, ngibe creative, like ngibe active, ngikwazi ukwenza izinto ngendlela, angikwazi ukuthi ngicabange into mase ngithi ngizoyenza kusasa, ngicabanga manje ngiyenze manje. So lokho ngathini iyona nto eyenza ukuthi ibe active. Bese ukuthi i-disadvantage yaleli drugs engilisebenzisayo awukwazi ukuphefoma kahle when it comes to intercourse, and then mese kuba ukuthini kunalezi zinto ezenzakalayo ama-effects like enzakalayo emzimbeni wakho effects like enzakalayo emzimbeni wakho uyashayeka, amunca igazi, amafutha, kungabi namazinyo, ama-advantages akhona la. Usize engathi nama ngingakuthola lwe-rock just ukuthi abantu bafundiseke kahle nabanye because abantu bayayigijimela le nto ukuthi bafune bathi ibagcine i-active. So baningi abagcina bengenayo, lokho kugcina ukuthi kugcine sekulimala abantu abaningi. So lapho kubhebhetheka khona indaba ye-drugs. Mina ngicabanga ukuthi ko-sharp lokho.
Do you use?
Okay, so I part-time crystal meth, and reason why it's because of I'm not a person who drinks, so when it comes to like weekends or once in a month, then I actually wanna just have a different feeling, so that's what I would do.
Okay, and what are the positives and negatives of using the drug?
So the positives, I'll start with the negatives. The negatives are more like if you're a person that you let the drug control you, and if you're a person also if you can't start a day without using, surrounding yourself with wrong people, like a squad, like a little people. And also smoking in different places, man. Like in all these different places, it's just not safe. Positive is, I think each and everyone should have time whereby they are just not working hard, not stressing, not because like I don't drink, and you get people that when they drink, then they will irritate people that are smoking. So a person must have something.
I'm Khadija Abrams. I'm from Cape Town, South Africa. I am a substance abuser of crystal meth and mandrax. The positive side of crystal meth, I would say, is that you get things done that you don't normally do. And the negative side of crystal meth is that sometimes you hallucinate, you think things that is not true, you know, and it causes a chemical imbalance in your brain, which is clearly affects your mental health. And mandrax, which is my choice of drug. The negative side is that I have emphysema, sickness of the lung, but that wasn't caused by the mandrake, it was caused by weed. And the positive side is I'm more alive, and I think clearer when I'm on mandrake and per norm, yeah, and I would also like there to be a program for landlords and crystal meth users that place to go to, someone to talk to. You know, sometimes when you feel down, that when life gets a bit of you, and as you know, then you turn to what? Your substance. Which makes everything a little bit better for that time.
Hayi kamadam ngokanyiswa kamkhize ngihamba ePort Shepstone kodwa ngila eThekwini-ke ngokuzonciphisa inkinga yama-drugs enginayo. So ngiqhamuka kwi-Durban North TUE. Kwi-Durban North TUE I'm acting as a secretary. So nami i-drug choice acting as a secretary. So nami i-drug choice yami iyona i-rock. Manje i-rock iyakwazi ukuthi uma ngibheme yona nje ngizibone ukuthi cha nami ngumuntu ngibekile. Yonke into engiyenzayo ngibona cha ngakwazi ukwenza yonke into. Kodwa-ke inkinga yayo ukuthi ekuthenini iyangigqilana ngoba manje ingishintsha i-structure sami engiyisona. Yabo nje ngingaka angingakanga. Yabo futhi inkinga yayo ingilimaza amazinyo awasaphelele. Ungawabona ephelele kanje kodwa awaphelele. Kodwa-ke into eyinkinga kakhulu uthi noma uthi kade uthi ufisa ukwenza into, once wayibhema ufisa ukwenza into, once wayibhema usubhemile futhi kuyabuya ukuthi awu bengilambile kodwa manje angisalambile ngoba yini sengibhemile. Masewubhemile seyabuya back leya nto ukuthi awu bengicabange ukuthi kodwa ekuqaleni beyikuthathe as ukuthi vele uzoba right, uzoba stress free, kodwa after yona asikho i-stress free. Inkinga yami nje ileyo engilethelayo. Ngicabanga ukuthi ku-right okay, uma ngingathola usizo my bro, ngingathola usizo lokuthi ngoba manje nginenkinga yabo, angisakwazi ukuphila impilo enormal yabo, ngisho ngathiwa
My
nginemali.
name is Stephen, and my drug of choice is TUE. Basically, if you had to ask me what the positives and negatives are associated with use of TUE, negatives would be basically the financial situation and the money, and also I think your morals and values, the things that you're prepared to do that you weren't before. The positives, I think, definitely help with confidence and socializing. When you don't have TUE, you want to sleep and you're very depressed, and it's aching and it's not pleasant. Part of the services that I think that would be useful for us to have would be basically as well as like a harm reduction pack for smokers as opposed to injectors, with a lolly, a lighter, a mouthpiece, some water, perhaps cotton buds and alcohol swabs. And the treatment that I think is also required would be the use of services of social workers, like for groups and things like that, and maybe a treatment like the methadone that injectors have, maybe something for us if there was possible, and yeah.
May I apologize for some technical glitches? My apologies. But in closing, here's what we heard. People who use stimulants have different needs. Some want to stop, some want to stay safer, and some don't want, and some want to better their lives. All these needs are real, and all these needs are very valid. So we need to create harm reduction packs specifically for stimulant users. Make rehab and abstinence-based options available, but not only the only pathway. Provide clear, non-judgmental education about stimulants, their effects, and safer drug use. And viva for upscaling harm reduction services for stimulant users.
Thank you, Shawnee. Okay, so our next speaker will be Sarah Whipple.
Hello. Hi, everyone. Cool. Yeah, I'm Sarah Whipple. I'm going to be talking about harm reduction for meth. I'm a person who uses meth. This is informed by my experience and my experience working with hundreds, if not thousands, of people who use meth. It's definitely the most common drug in my region, and it's lunchtime, so let's get into it. Okay, so I think Sean did a great job of covering some of the reasons people use meth. I think a couple things to understand about meth, if you're trying to reduce harm, is the bioavailability. Unlike something like heroin or weed where you're burning to smoke it, meth vaporizes, which means that it's really susceptible to smoking, very bioavailable that way, which means your body absorbs more of the drug, which means that smoking is a very common way of utilizing meth, and it also gives people a better alternative to injecting as compared to other drugs. Of course, it's important to understand that the half-life is extremely long, much longer than any other stimulant. We're talking like 10 hours versus, cocaine less than an hour. So it's not something, you can stop using at 9 and fall asleep at midnight kind of thing. You really have to kind of plan around that really long duration. Something that really changed the trajectory of my meth use was understanding that the physical effects of meth peak hours after the mental effects, which means that, the high that you might feel, the rush, the good mental feeling, might fade in the first hour, so you're using again to get that feeling again. But just understanding that the physical effects, like the racing heart and the trembling and the GI issues and all of that, are also going to stack up later, So that's something just to keep in mind. Also really want to address a very prevalent myth in the United States, which is that meth decreases overdose risk for opioids. People think it wakes you up, right? But that makes it more dangerous, right? Nodding out is like a natural protection from overdose because it stops you from continuing to use, but without that nodding out, you don't realize how many opioids you're using, and you don't realize when you might be approaching a point of too much. Most of the opioid overdoses in the United States actually also involve stimulant use. So just to address that myth. I think we talk a lot about supplies, so I'm not really going to spend a lot of time on it. Supplies are listed out, what we give out. One thing I do want to address, if fentanyl, ever does arrive in the rest of the world, as I hope it does not, but that fentanyl test strips don't work very well in meth, something that we've learned in the early years. There's leads to false positives. At first we thought all of the meth in the US had fentanyl in it, and then realized that the fentanyl test strips just don't really work on meth. So you need to dilute it really heavily with water if you're going to test meth for fentanyl. So if you get fentanyl test strips and you're testing your meth and you think that the entire meth supply is fentanyl, it probably doesn't. It might, I don't know. All right, I want to talk about dental harm reduction. Obviously that's a big concern for people who use meth, but tooth decay is not inevitable. Even if you use meth, there are ways that you can protect your dental hygiene. A simple thing, putting the pipe past your teeth, right, instead of in your lips, past your teeth, and then blowing out through your nose, just limiting the amount of time that the meth interacts with your teeth and limiting it hitting your teeth on the way in. Meth is acidic, so it does cause, damage to your teeth, but that's just one strategy. Also, maybe the traditional morning, night toothbrushing routine isn't realistic for you, Like when you're using stimulants, very hard to keep those traditional routines, right? So instead of trying to follow that, 8 a.m., 8 p.m. or whatever routine, just brushing your teeth anytime you go to the bathroom, anytime you think about it, anytime you see your toothbrush. And it doesn't have to follow that traditional routine. Even every couple days is better than nothing at all. Using electrolytes, we give out electrolytes at the SSP I work at because water is not enough to address meth dehydration. You really need some extra boost in there. And dehydration is a major cause of tooth decay, so it's also important for your teeth. We also give out sugar-free gum and hard candy, which does two things. First of all, it prevents you from grinding your teeth, which is very common for meth use, and it also stimulates saliva production, which keeps your mouth more moist, and addresses some of that dehydration, which causes gum disease and all sorts of stuff. We also, give out toothbrushes, toothpaste, all this stuff at harm reduction programs. It may not be considered a traditional harm reduction supply, but it absolutely is. Also giving out Oragel. Oragel is one of the most popular things we give out, which is like a dental analgesic. A lot of people have tooth pain, just helpful to help with the pain. And then if you can work with dentists to help, do trainings for dentists about stigma, have dentists do free dental clinics, just increase some of the access to dental care. A lot of people, at least where I live, who use meth don't have access to dental care, and that only perpetuates the teeth problems. And then, having chapstick, vitamin E for your lips, keep them moist, help with the burns, all the things. Skin picking and popping, obviously big topic for people who use meth. I'm not immune, that's my arms. It's something that we all, come in contact with when we're using meth. But again, there are ways to reduce harm. There are replacements. That's what's called a picking pad. It's a silicone mat with beads in it that you pick out of it, so it can kind of replace that picking on your skin and give you something else to fixate on. You might find another thing to fixate on, like sorting, drawing, are kind of popular among people who use meth. But, replacement activities don't always work, not always helpful. So, there's also ways to reduce harm. Washing your hands before picking, wearing gloves. You can give out gloves at your harm reduction program to help reduce like dirt and stuff getting into sores. Also, if you get acrylic nails, it makes your nails less sharp and it makes less damage when you pick. Just FYI. And then after picking, washing the area, putting antibiotic ointment, Band-Aids, gauze, and try to avoid self-stigmatizing. There's so much stigma for people who pick their skin, and it's nothing to be ashamed of. Sean covered this beautifully. Rest, sleep, so important. Having that hydration and nutrition. Even if you can't sleep, just laying down and resting your eyes can still help. Rest your body and mind, even if you don't get, a full 8 hours sleep, and if that's not realistic. Also, maybe trying to weigh or measure out doses to understand how much you're using. It's so hard. It's so easy to lose track of how much you're using when you're using meth. And then timing use, if you want to be asleep at midnight, you got to stop using in the morning, it's really long use. So just something to keep in mind. At the end of the day, though, there is kind of a long-term impact on dopamine receptors and pre-existing conditions, so there's not like a magic way to avoid paranoia. Sleep is helpful, but, there also might be other strategies involved. Last but not least, safer sex. Meth is very commonly used in sex. There's a whole culture around it for chemsex in the queer community. Also, many other communities use meth to enhance sex. Just a couple of strategies. If you want to use condoms, but you don't think you'll be in the headspace to do so while using meth, internal condoms can be inserted both vaginally and anally hours in advance, like 6 to 8 hours in advance. So that's something that you can do if you want to use condoms but don't think you will later. Also, something to keep in mind, because a lot of chemsex sessions last a long time, is that condoms should be changed every half hour if possible. Using a condom for 3 hours wears it out pretty well. And then setting out things like electrolyte drinks in advance, having, food and drinks near wherever you're partying can, help, because you're not going to go to the store and get an electrolyte drink in the middle of it. So just like having those things readily available, setting timers to remind you to rest, eat, and drink. And then just a reminder, poppers and Viagra are very common to mix with meth, but that can lead to stress on your heart and your blood pressure. Okay, we could talk about meth all day, and if you want to, that's my email, but thank you and goodbye.
Thank you so much. I would like to thank all the speakers for their wonderful presentation. Next, Angie.
Thank you so much, and thank you, our incredible speakers. Yeah, you can jump off. Unfortunately, we are running a bit over time. So we have played Tetris with the agenda. We're not going to do Q&As now. Instead, we're going to break for lunch. It is a bit early. Yes, okay, break. Great. Lunch is meant to be at 12:30, so we're going to break for lunch now. Please can everyone be back in the room by 1 o'clock, so we're shortening lunch, moving it around, and then we will dive into celebrating the Jude Byrne Award and then our amazing discussion on peer responses to incarceration. So you're welcome to go for lunch. I just want to remind people of 3 things. Translation, QR code is on the door. If you're going to, I know I'm going to be that person, don't judge too much. If you're going to be having conversations, please do it outside. It is a little bit distracting, and I know I'm also running around, but just out of respect for everyone. It's great. I love the enthusiasm. We're all excited about it. But please, we can chat outside. And last but not least, these doors are there are gaps in between, so don't stand here and have a loud conversation, or rather just go into the actual foyer. Please and thank you, and let's eat. Thank you. See you at 1 o'clock. Thank you, guys. All right, everybody, can we get settled, please? Ping, ping, ping. We can put it here. Ping, ping, ping. Ping, 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 ping. Matt, don't you feel like running around and like pinging people? Can you ping? Please, that would be amazing. Thank you. And this is mine. Where's my thing? Good shit.
Are you ready now? Smile. Here. You make my job so easy, both of you.
Alrighty. Ping, 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 ping. Ping, 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 ping. Thank you, Matt. Maybe like 2 minutes. Do you want a few minutes? There we go. Okay, we good. All right. Welcome back. Why is this thing making noise? It's my phone. Alrighty. Hi, everybody. Welcome back from lunch. I hope everyone is happily fed, happily watered, happily high, or whichever makes you happy. We are now going to go into the next session, which is a very, very special one. Just a gentle reminder, please, convos can happen outside in the foyer, not here. There is a QR code for translations. And naloxone, overdose-related things can be fetched from Sarah during the tea break or Jane, but we'll chat about that at the end. So, without further ado, I'd like to introduce Annie Madden to go into our next session.
Thank you, everyone, for a lovely welcome. It's such a pleasure to be here today. The Community Day is always such a privilege to attend, and I just love spending the day with my peers, and this morning, I'm sure you all agree, was just phenomenal and just amazing to see the incredible work that is being done in the region, and the stimulant panel was just absolutely mind-blowing. Yeah, I learned a lot, which was really great. My name is Annie Madden. I'm from the International Network of People Who Use Drugs. I have the absolute privilege and pleasure at Input of being responsible for the Jude Byrne Emerging Female Leader Award each year. It's a really special award. I'm going to take you through what the award is in a minute. A little bit of background. I know many of you know what it is already because you've been here before at other conferences, but for those who don't know, I'll do a little bit on that, and then I'm going to introduce our recipients for this year and give them an opportunity to address you. So I'd just like our recipients to come up and join me up here, if we can. Okay, can I have my slides, please? Someone. Is there a slide deck? No slide deck? I can do it off the cuff if I have to, but slides are better. I think that the slides are meant to be loaded and ready, and there should be a video as well. Sorry, everyone. Yeah, so just while we're waiting, I think one of the things I will say about the Jude Byrne Award is, as I say, it's been such a privilege to be part of it, is becoming such an important award within our community to lift up women within our movement, to support each other as women who use drugs, and to, most importantly of all, bring on the next generation of women leaders in our movement. I think that's one of the key things that the award does. Okay, great. That's all right. We can wing this. So unfortunately, we don't have the slides. So I'm just going to do what I, from memory, think is in the slides. So the Jude Byrne Award is in honour of an amazing, originally Australian activist from our global network of people who use drugs, Jude Byrne, known to many of you, I'm sure, but not, I'm sure, everyone. I feel like I'm feeding back. I'll try and stand back a bit so I don't annoy you. Does that sound better? Yeah. Jude, as I said, this award is an incredible award, and I think so in part because I think back about my own journey over 30 years of doing this work as a woman who uses drugs, and you know, there wasn't anything like this when I started in the movement. But I think I had something better, I might say, because I had Jude Byrne herself. She was my mentor. And a dear, dear friend who we lost very suddenly in 2021. Sorry, it never gets easy, this. And she was incredible, you know. She was a mentor to so many people in our global network, especially women who use drugs, but not only. She was a critical member of the Australian Drug Users Movement, a founder of the Australian Drug Users Movement, involved in the Australian Injecting and Illicit Drug Users League, better known as AVIL, for decades, which is where she and I worked mostly together. But also she was on a founding chair of the Input Board until 2015 for several years. She was instrumental in getting input off the ground and making it happen as a global network. She was also one of the first women who use drugs to set up projects and services specifically for women who use drugs, particularly in Australia. And I'm talking back in the mid to late 1980s and early 1990s, so a long time ago now. She was incredible. She was a mother, a grandmother, a member of our community, and a fierce, fierce advocate for people who use drugs. So it is an incredible privilege to be able each year to look after, to be a custodian along with INSUE. So it's a joint award with INSUE and Input, and we jointly are the custodians of this award. So each year we put out applications for women who use drugs to either apply themselves or to be nominated for the award. And we usually select 2 emerging female leader award winners or recipients. And we also have a new form of the award that we started last year. Angela was the first recipient, which is a special recognition award that we do. And this year we have 2 women who will also receive the special recognition award. And that award is to recognise what we realised in a couple of years into the award. We've had it for about 4 years now. And one of the things we realised was that we had a group of women coming through who were already reasonably well progressed on their leadership journey, but they'd done it all themselves without any real support. And they still were on that journey. They were already well progressed, but they were still on the journey. So for that, we wanted to have another award that sort of recognises that work they've done already and to support them further in their journey going forward. So I'm really mostly devastated I don't have my slides because we have just done a new project on the Jude Byrne Award. I will find a way. We do make this presentation again in the main conference on Thursday, so I encourage people to come along and support our recipients when we present them to the entire conference, which is really important. But there I will share the QR code for this new resource that we have developed. We got Input had a small amount of resources, and we got an amazing consultant, Jess Whitbread, to do a impact assessment for us on what the Jude Byrne Award has been able to achieve already just in its first few years. And we've managed to do interviews with the previous recipients up until this year. So not this year's recipients, but all the ones that have come before. And they all gave generously of their time, did an interview and told us about the impact the award has had on them and their communities and each other. And it is incredible. We did a mapping, an impact mapping in that resource. So you can see visually how all the women are now connected to each other, how they have gone on to achieve incredible things because of the support from the award. And it's a really inspiring image to look at about just all of how it all connects and all of the amazing things that have happened for everyone. And then there's a short summary of the key takeaways from that image, if you like, of what the key themes are. So as I say, I wanted to share that QR code with the community first so you could see it first, but unfortunately that's not going to happen right now, but it will happen on Thursday if you can. And it's going to be available from now on the Input website as well and on the TUE website, so if you go there you should be able to find it there. So without further ado, I want to now focus on our recipients for this year. So we'll let the recipients introduce themselves. We have 3 people sitting before you, and as I said, we have 4 recipients. So obviously someone isn't here. So Joanne Canedo from Portugal is one of our recipients this year for the Special Recognition Award. She isn't able to be at INSTU, but I will introduce her myself later. We do have a video from her, but I'm suspecting we don't have that to show you either. So if we don't have the video, oh, you do? Brilliant. Okay, great. So we have the video, so that means that we will, Joanne will be able to speak for herself. But before I introduce Joanne, I want to start with our Emerging Female Leader Award recipients this year. So first of all, I'm going to introduce Kumba Akufo. Kumba is from, sorry, let me just get myself together here. So Kumba Akufo is from Namibia, and she's going to, first of all, address you and talk about the importance of the award to her work and her life, and also to talk to you a little bit about issues for women who use drugs in her country. And then I'll introduce the next person.
Thank you so much. Firstly, I'd like to start by thanking Input and INSTU for this amazing recognition. Winning this award, I don't know if I even have enough words. It's so surreal. It's like the ultimate dream for someone like me. So my name is Kamba Koswa Akufo, and I am from Zambia. I am the work team's coordinator for the International Network of Formerly Incarcerated Women. I am also a co-founder of Formerly Incarcerated Women Africa. I am the co-founder of Titandizani Comfort Homes in Zambia, and I recently founded the Zambia Network of People Who Use Drugs. Coming from a country which is like one of the poorest countries in the world, and being someone who has faced a lot of harm from using drugs, this award means a lot to me because it brings to light some of the challenges that we face in Zambia, that we have very little harm reduction going on there. Personally, I feel like there's really nothing available, because for me, the only thing that was available was a mental institution and rehabilitations that were very expensive. So for me, it's really, really exciting to be able to highlight this and be able to bring harm reduction to people in Zambia, more especially for the women, my dear sisters. Zambia is currently going through a lot of issues and being recognized for this award and having my different roles that I carry. With the international network, I advocate, and I have spoken in Vienna, I have spoken in Geneva, and so it's really, really great to have this on my CV. Currently, we are advocating for non-custodial sentencing. We have an advocacy called Free Her, where we're advocating for non-custodial sentences for women, because in Zambia, even just community service is quite challenging. The first recommendation is for you to be incarcerated. So I've done a lot of work with women in prison, and now I really want to go to my community. So last year, when I attended INSHU, I felt like I found my people, and I was so happy to join INSHU. I was guided by my dear friend Ahmed from the African Network of People Who Use Drugs, and we formed our network in Zambia. And together we did the 15 days of activism against gender-based violence. Truly, standing here today feels like a dream because I faced so much harm. I remember there would be days when I would be in my community in Chiwalia with literally no money, literally no food, and no hope, you know. And ultimately going to prison and joining the international network has elevated my pain and turned it into purpose. And I really believe that with this award, I can then turn that purpose and be able to help my fellow sisters who have gone through what I have gone through. Annie is mentoring me, along with so many other people, to set up a women's shelter in Zambia. We plan to have a shelter, a women and men's shelter, where we can have HIV treatment, TB, needle and syringe programs, and be able to help our women live a life with dignity. So this means a lot to me. Thank you so much.
As you can see, we have an incredible group of recipients this year and every year. Just to add a little more to the award, remembering what's on my slides all the time as we go, we do get a lot of applications for the award every year, and this year we had double the applications we had in the previous year, so the award is really growing. So we had over 50 applications this year, 40, some of them were double up, so 40 individual ones in the end. But, you know, it's a very competitive award, and if people have applied for the award in the past, I just encourage you always to keep applying, because the moment can just be right for you to be the person, you know. So don't feel like it's a rejection of you if you don't. It's a very competitive award, but we always encourage people to apply multiple times and to keep putting themselves forward or be put forward. So without further ado, I want to introduce our second Emerging Female Leader Award recipient this year. Velta Palkamento is from Ukraine, and she's going to address you now.
Thank you so much. It's really honor to me to be here. And when I got this message about the award, I was in Lviv, and we conducted with my friends, my sisters from community, training to our sisters in Lviv about improve advocacy skills. And when I saw this message, I said, wow, is it true? Maybe it is scam, I don't know. And I have shown this message to my friends and say, can you translate? Maybe I missed something. Yeah, and for me it's really important. And I want to share, when I was 18, I came to a community-led organization in Ukraine, Club NA, for clean syringes, needles, and it was first place where these people did not say me what I need to do, what I need to change, that I need to stop drug using right now. They just ask me what I need and give me their support with lawyers, with needles, with syringes, with HCV treatment, and other. And they propose me a job. They say that I am 18 years young woman, and I am a drug user. And they say you can support and help other people from your community right now. You don't need to change your life because you have really your life and experience to share this. And they pay me money for this. Yeah. And I think it was first miracle in my life about changing. And from this, for now, it is many years, more than 20 years, I'm staying with people from my community. In Club NA also, I was a client, now I'm chair of organization, and they have really strong team of women. And also I'm a member of Eurasian Network of People Who Use Drugs, International Network of People Who Use Drugs, and Women in Harm Reduction International Network, because I want to change this situation and make needs and problems and gaps of women who use drugs more visible, because often we are invisible. And I faced with violence, with rapes, with violations of my human rights, and I haven't any support because most of society say me that it was my fault and it was my choice. Yeah, and I don't want to live in a world where my sisters can be in this situation and hear these words. So I want to change this. It is my simple goal to achieve, I hope. Yeah, and in Ukraine we have a war situation now, so we have a double war situation because we have war with drugs in Ukraine and also war from Russia to Ukraine, and I live in Kyiv, so it is almost every day we have rockets attacks and drones, and we have bomb shelters, and it is scariest. But we see that other worlds support us. And I think when it was started full-scale war in 2022, it was choice for us. We can just as frozen and stop our lives, but we have other choice. So I chosen to continue my life, to support my sisters, and to increase services for people who use drugs with focus on women. So in 2022, we sent a shadow report to CEDAW committee about violations of rights of women who use drugs in Ukraine. And CEDAW committee gave recommendations to our country, and one of these recommendations was to increase access of women to shelters in situation of domestic violence, because we have discriminated rules of the state shelters. And Ministry of Social Policy, they changed these rules. And it is my and my sister's advocacy win. Yeah, because for now, our state shelters not discriminated women who use drugs, just only for drug using. Yeah, so, and it is during the war situation. Yeah, we can change and increase politics. And also we adopted a methodology for support women in situation of gender-based violence, women who use drugs in 16 regions of Ukraine, and we continue this work. And so I think that if I have my sister near me, we can do everything. We have no fears because I think I tired to fear. I don't want. I am brave, I am strong, I am a real expert in my life, and I am good mother, good wife, good sister. And drugs or any my choice, they don't change this position. And thank you for you all. For me, it's really sensitive emotions to be here and see all your eyes. And together we can more and more. Thank you.
Got no words. Angie and I were just looking at each other, just crying. I'm sorry. Thank you, Velta. That was incredible. And some of you will know, but the committee that Velta referred to, the CEDAW, is the Committee on the Elimination of Discrimination Against Women, the UN Committee, the Elimination of Discrimination Against Women. That is a significant recommendation to get through at that level. Unbelievable. Congratulations and thank you. Okay, without further ado, I'm going to move on to our special recognition recipient awardees this now. As I said, not both awardees are here, but Rita is here. You've met Rita before. Rita Gatoni from Kenya. I know she's known to you all. I know she's already presented today, but in this case, she's going to address you as a special recognition awardee for the Jude Byrne Award, and a very well-deserved award at that. Thank you.
Okay.
That was meant to happen.
That's emotion for you. That's all the emotion. Yeah. Please feel free to laugh at her later over a drink. So again, hello everyone. My name is Rita Gatonye. As I said before, I was born in Kenya. I coordinate a network of women and young people who use drugs in Kenya, Uganda, Tanzania, and now Burundi, Zimbabwe, and we have a representative from Nigeria. I also am fortunate to sit on the board of the International Network of People Who Use Drugs as the hand holder of the International Network of Women Who Use Drugs. And I'm happy to be here with you today. So I almost didn't apply for this award. And the reason why is because I think it's the same thing for a lot of us. It's very difficult for me to understand, it's in Africa especially, why somebody should be rewarded for doing the right thing. We're just doing the right thing, for putting humanity first, for working so that people can have a better quality of life. But then I went to the harm reduction conference, and two of the previous awardees literally forced me. Thank you, Angela. Thank you, Sarah. Literally forced me to apply. And I thought about it. And then I realized this wasn't about me at all. This is about the women that we represent. It's about the women who still believe that their voices don't matter and will never matter. It's about the peers who keep showing up to do the dirty work of saving lives, even when the system doesn't respond, even with constant violations. The women who do not give up, even when their voice shakes. It's about our friends and families that support us even when they don't understand us. For me, this is about my father who at 75 years old got on a rickety motorbike in Nairobi to save me from withdrawal because the clinic wouldn't dose me with my methadone. This is about the women seated next to me, who so deservingly are in this position. This is about the women, the people who we lost, the friends of ours who have passed because of criminalization and because of the policies that we fight against today. This is about the people who don't have the privilege of standing in front of you today. This is about Jude Ban, who I unfortunately didn't get to meet, but whose work and who I have learned was a radical, brave, kind, to a fault human being, right? Very non-apologetic about honoring the expertise of people with lived experience and on seeing people as just people. This is about the people who worked with Jude. This is about you, Annie, and everything you've done for the drug user movement. This is about you, Robin. This is about you, Jane. This is about you, Angie, Shanae, Nat, Fiona, Amanda, Violet, all the women who use drugs, and the way we've held each other's hands through everything. This is a reminder that our words, our stories, our work are powerful tools of change, not in spite of the life we've lived, but because of the life we've lived. I hold this honor with both of my hands and all my heart. Standing on the shoulders of giants, I have no choice but to keep using my voice and my privilege, because I am privileged to be with you today, to keep opening doors for those who are constantly being shut out. So Input and Inshu for seeing more in us than we have the time or energy to see in ourselves, because it's work, work, work. Thank you. Thank you for being the stars that continue to light the way. Thank you, everyone.
I know. Angela and I can't even look at each other at this point. Yeah, amazing. I'm going to move on to Joanna Canedo, as I said, is not with us. Joanna is a passionate activist. She would have loved to have been here. We just couldn't make it happen for her this time. She fights for the rights of people who use drugs and women who use drugs in her everyday work. She's a member of the executive committee of Euronpud, which is the European network of people who use drugs. She's also a local campaigns coordinator and researcher at that network, and is part of the women's team, which is called the Sisterhood, which I love. Joanna is also volunteers at Manus, which is a grassroots collective based in Lisbon in Portugal. She's from Portugal. She has recently been living in Mauritius, but is currently based in Luxembourg and is conducting her PhD fieldwork as we speak. I'm hoping we have a video from Joanna to speak for herself.
Hi folks, here is Joanna from Portugal, right now speaking to you from Luxembourg. I'm truly honored to have these few minutes to talk to you about the awards we have received, the Jude Barn Award. And I want to first of all to congratulate the other recipients, Kauma, Vielta and Rita, for their work and dedication to the community of women who use drugs. This award means a lot to me because it supports the space where research and activism meet, where knowledge grows and also lived experience, and where care and resistance also come together. Through this mentorship, so the award gives me the opportunity to have some mentorship sessions with some experts. I hope to learn how to do research that sustain the activism I do. Sometimes it's difficult to join both of them, and how to make it useful, mostly ethically and accessible for our communities. For me, this is also about the sustainability of the projects I'm engaged with. So for those who don't know, I'm part of a collective called Manas, based in Lisbon. It's a collective of women who use drugs and reduce sex work. We've been active for the past 5 years without any state-led funding. And so addressing these challenges is also now possible through this mentorship. I do believe that grassroots solutions have a lot to do with the harm reduction approach I want to see in the world. And I'm thankful to our international allies that make this project keep on going. It is also about strengthening the work I'm doing at EuroInput, the European Network of People Who Use Drugs, connecting local voices and enabling drug users groups and unions to do campaigns and to then connect to the European level advocacy, creating space for people who use drugs to organize, to speak, and especially to lead. I believe that existing, caring, and organizing together, especially as queer people, women, young people use drugs, is a form of love. And because when you truly know your community, I believe you know how to get the things done with care, with honesty, and with the kind of radical tenderness that keeps reimagining the systems that we live in, that we want to live in. So yeah, I'm thankful for the opportunity of having received this award, and I wish you all a great conference and a special community day at TUE in Cape Town.
They are an incredible group of women who are doing amazing work in their communities and with their communities. And I just would like you all to stand and honour them now. Thank you.
Wow. Congratulations to the 4 most magical women, powerful women. What a powerful experience, and being able to share that and here at this busy, beautiful space. I am now going to hand over. Is that working now? Yeah, okay. I'm now going to hand over to Louise so we can have a chat with Kumba. Why?
It's the 2 microphones.
Yeah, that's why I'm like, there. There you go. I'm not talking to this one. I'm now going to hand over to Louise so that we can have Matt and Kumba back on the stage. And Julia. Yes, and Julia. So we can have a nice panel discussion on peer-led responses to incarceration, and I can cry quietly in the corner. Thank you so much. Over to you.
Which one should I use?
See, I think we should just sit.
Yes. And then shall I sit down?
Hello everyone. I've got to say, in all my years of doing INSHU, this is the most impactful community day and the most attended. Thank you everyone, and it's always a pleasure to go after Jude Byrne Award winners because it means a lot. My first INSHU, I met Jude, I spent time with Jude, and that's why I kept coming back. So yeah, thank you and congratulations. So we're going to have a bit of a panel discussion. The format is going to be that Matt, Kumba and Julia are going to share a little bit about their experience, and then we'll open up the floor to any of you. This is really weird. I don't know. Turn one on. Yeah, and then we'll open up the floor just to ask some questions. We are going to try and make up a little bit of time as well, so we're going to shorten the session a little bit. So I'm going to introduce Julia, and I'm super excited because in previous INSHU pre-events, we've had the prison network have had a full day. So because they've moved on to bigger and brighter things now, we've got the immense pleasure and privilege of having Julia come to our community day. So Julia is the Women's National Prison Coordinator for the Hepatitis C Trust, which is an incredible charity in the UK. So I'm going to pass over to you, Ju.
Can you hear me? Oh. Hi everyone. Yeah, my name's Julia Sheehan, and I'm based in the UK, and I work for an amazing charitable organisation called the Hepatitis C Trust, and I work on the women's prison team. So I oversee a lived experience peer programme across the 12 female prisons in England. Firstly, I want to say I feel so privileged to be here, and I'm nervous. I always get nervous, and I have to face that fear and do it anyway. So I'm going to talk a little bit about my own experience. I have lived experience. I used drugs for 25 years plus. I've really been thinking about it because I've heard lots of people's experience today, and I've been thinking about my own experience over those years, and being caught up in the criminal justice system in England and how it was really focused towards abstinence. I got sentenced to things called DTTOs, which were drug testing treatment orders, where I had to provide clean urine screens, and I had to sit in front of judges and tell them what I was doing about my recovery. And they had pots of money for detoxes. I'm really aware that I'm from a high-income country, and I had lots of opportunities to do detoxes and rehabs, but it's really got me thinking today of how really focused on abstinence they were and still are. So I found what worked for me, and in 2015 I served my last prison sentence in quite a notorious prison in London called HMP Holloway, and I was in a bad way physically. I was an injecting drug user, so I had all sorts of things started going wrong. I had ulcers in my legs. I had DVTs. I self-cleared hepatitis B, and I had hepatitis C. And on that prison sentence, I don't actually remember saying yes to a bloodborne virus test, but I think I did. I think going through the reception process for me was just really traumatic. I was often in huge withdrawals and, really needing OAT, basically. So, but I must have said yes and flagged up as having hepatitis C, and an amazing doctor used to come in and treat women in Holloway. Holloway's gone now, it got shut down. It was very dilapidated and not in a good way, a bit like how I was. So this doctor who I get to work alongside now, he was amazing and used to come in from the local hospital and treat women that needed curing of hepatitis C. And he brought me down into healthcare, and he needed to draw blood from me, and that had to come from a vein. And I was very difficult to to bleed, and that never happened. So I ended up leaving. There was nothing. There was no point of care tests, finger prick tests, or mouth swab tests back then. So I left prison with Hep C still, but I became abstinent 10 days after I came out of that prison sentence. I was very lucky that somebody paid for me to go into detox, and in 2017, I started a course of DAA treatment and was cured of my Hep C. And I was diagnosed in 2007. So to me, it was like a miracle. And it really changed my life and changed the course of my life. And I never knew what I wanted to do because I'm not academic, and that just hasn't been part of my story. But I knew I was bright, and I knew that I had transferable skills because I supported a drug habit for many, many years and did it pretty well. So I knew that if I put all of that energy in something positive, that the world could be my oyster. So I started volunteering at the Hepatitis C Trust, and in 2018 I got a paid job with them, and we rolled our peer program. We already had a peer program in the community, and we rolled it out into the female prisons in 2018. And we deliver bloodborne virus harm reduction workshops. We support testing and treatment pathways. We deliver something called HITS, which is high intensity test and treat events. And we have a volunteer peer program within the prisons. We're pretty embedded because this is what is coming up to 8 years later. So I'm also aware that I think we're quite lucky in the UK that they allow people with lived experience of prison back into the prisons. So like in my experience of doing conferences and international conferences, I think that's quite a rare thing. It doesn't happen everywhere. So I'm very grateful that our prisons allow that. So I work with women in prison, and there's been lots of talk about women today, which makes my heart sing. And women in the UK face significant issues, including domestic violence, self-harm, experience of poor mental health, and I definitely felt the full force of stigma against people who use drugs within my using within prison, within hospitals, within whatever area in my life. So the little bit that we can do to improve a woman's life in prison makes my heart sing, and myself and my team do it with such passion. The system is almost built to keep women there. So if we can, advocate for women, encourage women to have a test, empower them to make the decision to have a test and accept treatment and support people through treatment, then we're doing something that's pretty good. Outcomes. So the Hepatitis C Trust, our ethos is that at the core of everything we do are our peer volunteers, and our ethos is if we can employ them, then we will. And I've got some quick data here. So per year on average, we have 190 active peer volunteers in the community and prison. 47% of those go on to paid employment, and 27% are employed by us at the Hep C Trust, which I think is incredible statistics, and it definitely was for me someone who I never thought that I would ever get paid work. I really had written myself off, so I'm very grateful to the Hepatitis C Trust. Where do we go from here? So we're doing an amazing job in the UK in terms of eliminating hepatitis C. Lived experience is important, and honestly, my lived experience of Hep C is very helpful for someone who has Hep C, but I think the overarching experience that I have to someone in prison is that I'm an ex-prisoner. It's like it's the kind of magic ingredient. I think anytime you share, it's the whole thing of like lived and living experience. When you share an adverse situation or a difficulty, it's like a connection happens and a bond happens, and we're able to reach people that maybe other people can't reach. So I would hope that we could broaden our reach, maybe, broaden our healthcare and support with vaccination programs, screening programs, cancer screening, another non-cancer screening. I think there's a lot of work out there for us to do and that we can support in, and I don't know what else to say. I'm very grateful to have this opportunity though, Louise, and I'll leave it there. Thank you.
Thank you, Julia. And the Hepatitis C Trust and the work that you do and that you lead on is just, it's phenomenal. We've really, really shown the power of peers in the UK. I feel very blessed to have seen the movement from inception to where we are now. Thank you. And then I'm going to hand over to Matt, who I met in 2019 in Montreal. Matt probably needs not much of an introduction, but I'll hand over to you.
Thanks, Louise, and thanks everybody here for making such a wonderful community day. You can really see the vibes in Cape Town, and it took a lot of us a lot of way to get here, and I'm just glad that we're all here and we're able to spend some time together. So yeah, my name's Matt Bond. I'm someone who uses drugs. I've been involved with INSU since Louise mentioned 2019. I'm going to speak about a program that I helped lead back in 2019. It was actually my first INSU poster that I ever got accepted, but I was always doing so much community work and I was never involved in the prison stuff, so we thought it would be good to talk about some of the prison stuff that maybe got just pushed aside because of the special interest group. But in Canada, we have two different incarceration systems. We have a provincial incarceration system and a federal incarceration system, and it's kind of ironic because if you do more crime and you do longer time, you get more support. You go to a halfway house. There's more, you get on opioid agonist therapy in jails. You have more programming. There's more, you can do your own cooking. But if you're on remand, or if you're just charged of a crime, or if you're doing less than 2 years, you're kind of stuck in a really rock and a hard place in a pretty not so nice place. So I helped lead this program called PALS. It was called Peers Assisting and Lending Support. And it was a 28-month program that got funding from the Public Health Agency of Canada to do outreach and in-reach with one particularly bad jail in Nova Scotia, which was called the Central Nova Scotia Correctional Facility. And the reason why I say they were bad is just because they had bad policies and programs. One example was like everybody that is on methadone, any males that were on methadone would get strip searched every day before and after their methadone as like a prevention or a prevention mechanism so people weren't diverting their methadone. Instead of just starting people on methadone, they would actually strip search people, and there's been this long institutional kind of traumatic things just with, strip searches and, sexual misconduct, particularly in the correctional system in Nova Scotia. So we started this program to actually go to the Central Nova Scotia Correctional Facility, pick people up as soon as they get out, because if you're getting out from a provincial institution, you don't get anything. You're lucky if you get a bus ticket. But a lot of times they just give you what you came in. Sometimes you'll often see people in the street wearing just they call them the jail slides and the jail outfits that they have, because they might have blood on their clothes, or their clothes are taken as evidence. So you literally have nothing. So we took pictures of us, and we did all these trainings and all these trainings with people who were actually in jail, and we took pictures of us, and we put them on all the different ranges where people were. They would call our local opioid agonist therapy clinic, Direction 180, and they would say, look, I'm getting out on this date, I would like a pal to come pick me up. So we would go right to the jail, pick people up, we would take them out, we'd take them to get breakfast, take them to get their medication, we'd give them harm reduction supplies, train them on naloxone. A big thing that kept coming up, people just didn't have anywhere to go. So, we would go get them a new outfit, we'd get them an ID, we would give them naloxone, we would go help them buy drugs if they wanted to. Like, we would do all that for them. But at the end of the day, we had nowhere for people to go, so we would have to drop them off at a shelter. The overall objective of it was to reduce risk-taking behavior from 75 to 100 people who use drugs at that critical time upon release. As we know, people's tolerances are down. They think they can use as much as they did when they were going in. And yeah, it's a very hectic time for anybody. Like, even if you just do 30 days in, you could lose your housing, you could lose your job, you could lose your family, relationships. So it's always a very hectic time getting out. So just to have, people that you can see a picture of them, go and pick them up, it was a huge impact. Like, I don't know how many people I knew, they'd be like, hey, Maddie, is that you? Is that you, Maddie? And we'd take them to go pick up their safe supply, and they're like, are you sure I can go do this? Am I allowed to use? And we're like, dude, that's why we're here. We don't want you to, overdose and die. And, it was just, to me, it was one of the most impactful programs, and I've been a part of a lot, but it was one of the most impactful programs that I've ever had the opportunity and the privilege of being a part of. And we collected data, of course, and we published some interim findings on Katie's website. So this was from February 2019 to March 31st, 2020, so right at the height of the pandemic. And that's when a lot of these programs changed and didn't get funded, or they, we had to start sending cabs to get people and meet them, and the engagement wasn't really there. But all of the 44 people accepted at least one type of supply, so either a using supply or hygiene supply or naloxone, and at least one referral to a service. More than half indicated that if it wasn't for the PALs, they would have not have accessed naloxone, safer supplies, or been able to get an identification or health card. And a lot felt like they wouldn't have felt comfortable using naloxone or even accessing safer drug use equipment from the local needle and syringe program if somebody didn't kind of go there and hold their hand and walk them right through that. Over 75% of people reported PALs reduced their risk of hepatitis C and HIV, educated them on the risk of overdose following release, and helped them get an ID, transportation home or to appointments, or connect them to health or social services. 5 people were taken directly to an opioid agonist treatment upon release. How things are funded in Nova Scotia are typically through our Indigenous, Mi'kmaq Native Friendship Center, and then they fund a program which would be like your opioid agonist therapy program or your overdose prevention site, and then they will apply for separate little pots of money. So that's how we kind of ran it. So that's why like some people, if they had an appointment at Direction 180, they knew they had to go and get their methadone. They said, well, why not? I'd rather someone come pick me up than take the bus. And all people were referred to at least one organization for support, and many accessed important services like needle and syringe programs, criminal justice support offered by the Elizabeth Fry Society, food or income assistance, substance use support groups, primary health care services, or housing and emergency shelter services. You know, like when you get released, you don't have a phone a lot of times because it's either taken away, because if your charges have anything to do with drugs, any cash you have, any phones you have are all taken into evidence. So just to have that like connection as soon as you're released, it just, you know, just like takes somebody to get like an egg McMuffin from McDonald's, like the joy in their eyes was like one of like the most impactful things. And you know, we think about all the things that are funded and not funded, and how many billions of dollars go into building prisons and, you know, giving CO guards, workers money, like the unions monies. I just think it's like we could do so much with such a little amount of that. We need to really look at more sustainable options and more effective solutions for people who are incarcerated.
Thanks, Matt. Incredible work and really life-changing, that peer support and being there for somebody when they leave custody. Thank you. And I'll hand over to, how do I say it? Kalba.
Yes. Good afternoon once again. So I just wanted to talk about a bit of my story with incarceration. I was incarcerated in January of 2020 for about 4 months. I call this one of the hardest experiences of my life because I was arrested at a time when I really needed a lot of support from my family and my colleagues, but I feel like everyone gave up on me. The only person who really did not give up on me was my spouse at the time, who is currently my husband right now. When I was arrested, he came and he told me that it's going to be better, and he supported me through everything until the day I was released. So I was arrested at a time when I was taking a lot of heroin, and being taken into police custody without any treatment was the worst. I literally was on the floor. I remember being on the floor and just trying to feel the cold floor to help me with my withdrawals, because I could feel it in my legs. I could feel like I'm so restless. I couldn't sit still. I was just so restless. And the police now, they were looking at me and saying like, she's an addict and she's gonna stop. And you know, and I remember one police officer, I was telling him, could I have a cigarette? And he was just like, we don't allow cigarettes over here. And he went to the back of the cell and he was smoking and looking at me and he was blowing in my face. And that was really painful. And then my cousin brought me some cigarettes. It was Charleston police station. They didn't even allow cigarettes. So when they smelled the smoke, one of the officers that was from a police station near where I lived was really, really just so keen on making my life hell.
he came and said, it's her. Like, I know it's her because I was the only one in that cell in particular. So they came and they beat me up with like short buttons in my legs. And I was literally like at the worst point. I was feeling confused. I had a court case. I didn't have money to get a lawyer. My family came, but it's literally like they give me food. I can't even eat the food. I can't sleep. I can't drink anything. I'm literally pacing up and down in the room. I'm helpless. And there's nothing they can do, and there's nothing anybody can do. And so I would actually go to the point where I would go and there was some naked wires in the ceiling. I would go and spark them just to turn off the electricity, just to piss off the police. So they would come and beat me up again. But for me, I don't know. It was just really just a whole lot of confusion. So I got to a point where I felt at my lowest. I know it was withdrawals, just probably taking my emotions all over the place, but I just felt like I had enough and I really just wanted to die. I remember getting a fork and I was sharpening it on the floor because I just really needed to get sharp. And then the officer in charge, because they kept checking my cell all the time, they got the knife. And I remember looking and trying to actually find some way to hang myself, but I didn't have anywhere to step on. I had a chitenge, which is a rapper, an African rapper, but I didn't have anywhere to hang it. And I remember waking up the next morning and I said, you know what, God, if this is what you've destined for me, then I accept it. But I choose to live my life with joy, and I will try to be strong, and I'll try to do what is right. And so it was hard still. Going to the prison, I was thin because I hadn't eaten for a long time. And the captains there would bully me constantly. When I got there, in Zambia, they have this thing where they say like, oh, you're from outside. Could you show us some of the dances that they do outside there? And I was telling them like, I don't even have energy. And they're like, oh, let's make you sugar solution. So they made me like sugar solution. And luckily, it was interrupted by the officer in charge. But it's just those things where they would make me work even when I didn't have the energy to work. And do a whole lot of things. Being in prison really changed a part of me, and it gave me resilience. I left that place and I joined the International Network of Formerly Incarcerated Women. Today, I'm the work team's coordinator in this network and is present in 25 different countries. Together with my sisters, even when I stand at the UN, I tell my story about how I feel like the system in Zambia when it comes to dealing with people who use drugs should change. And we have been deliberating strongly on how we could partner with IDPC and Women Beyond Wars and the World Coalition Against the Death Penalty and try to advocate to decriminalize drug use. As the CEO and co-founder of Titan Designer Comfort Homes, I do help women coming out of prison by having a cohort where we train in entrepreneurship and then be able to hand out some start-up packages. We are hoping that with the network, we can represent women with lawyers and women and men who go to prison with lawyers and be able to at least get them out, because there's, I hear there's a rehabilitation center, well, I know it. There's a rehabilitation center in Zambia that the government allows people who use drugs to go there. So our clients would probably go through that rehab and have them get alternatives to incarceration. Because having gone through that experience, I wouldn't wish it on anybody. And so even just winning the award for me, it's really coming in to help my work as we begin our campaign, which is Free Her, like I said earlier, to advocate for non-custodial sentencing for women. I believe that I am a voice for the lovely sisters in Zambia, and I would do everything in my power to try and help women and men who use drugs in Zambia. So thank you so much.
Thank you. So I've got a question to pose to the three of you, just in a couple of minutes. Could you talk us through the challenges that you've faced and how you've overcome those in some of the work that you've done? So would you like to start?
Okay. So this is why I'm so happy to have won the award and to be part of this lovely family and show an input, right? Because the one thing that helped me stand throughout a woman who uses drugs and a woman who's been to prison is being part of a community. I was telling Annie yesterday that one of my sisters, Andrea James, today is her birthday, by the way. She's standing for governor in Massachusetts. And when we met in Colombia in 2023. When I hear women's stories all over the world, when I see their struggle, their fight, I stand tall and I feel a certain passion in my heart. And that helps me overcome any stigma, because my sisters would just be like, yo, I did that, so what? You know, like, we move on and we fight the fight. We fight to change future generations. I fight because I don't want to see anyone go through what I went through. So that's answering your question.
Julia?
The thing that springs forefront, I know that I made it sound really easy when I spoke about access into prisons in England. It wasn't as simple as that. There was a policy in place for people with lived experience to come back in, but actually on the ground it wasn't really truly working, so we had a lot of challenges. There was a lot of times that I had to dig deep. Rachel Halford, my CEO, will remember there was a time when one of the governors said, to be honest with you, we've got enough issues with drugs in our prisons without giving Julia a set of keys. I was so upset about that, and I thought, oh, it's never going to happen, I'm not going to get back in. But I dug deep and I thought, I'm going to fight this. And you know what? We did challenge that governor. And to be fair to him, he did admit that he'd been a bit hasty and he made it right. And he contacted the other governors of the 10 other closed prisons to encourage them to give me a set of keys as well. And I think, in the years, I think the prison peer program, because it started off in the men's prisons, been going for about 9 years now. So we've really evidenced that we're trustworthy, we're reliable, we really make a difference to people in prison, and I think that a byproduct of that is we've made a lot of change in that process, probably for other organisations as well. So yeah, it wasn't as simple as I say, but I feel like we've got there. There'll always be the odd governor that will be a bit dinosaur-y and not believe in rehabilitation, because that's essentially what they're saying. And my experience is that I would be the last person that would be bringing drugs in to their prisons. And that's the bottom line. Maybe they would need to be looking at their own staff rather than us. Yeah, thank you.
And Matt?
Yeah, I think Julia's points about getting back into the prisons once you are someone with lived experience or you're someone who's formerly been incarcerated is a unique challenge experienced by people trying to do this work. I know for us, like, we wanted to go right back into the prisons and say, like, this is who the pals are, this is who's going to be picking you up, there's going to be a staff person driving, but at the end of the day, you got the two pals. And we really kind of, like, we were getting very close to doing that, but we all had criminal records. And just having those criminal records at the end of the day, they said, you know, you can't do it. So, you know, we took pictures of ourselves. We would answer the phone 24/7. But yeah, I think, you know, trying to prove your value and your worth to people who already think the lowest of you it's a really hard thing. And I know for me, like when I was spending time in jail, like that's when I was at my lowest as well. And like, I just know your family leaves, your job leaves, you're usually homeless. So like if there's any kind of support, you know, somebody to pick you up and take you to an appointment or get you an ID or take you to a shelter, like that goes a long way and it's really impactful.
Thank you. So I've really heard that resilience, that tenacity, that perseverance from the three of you. Thank you. So we've got about 5 minutes for any questions from the floor, if anybody would like to ask the panel anything. I don't think we've got a roving mic though. Gentleman at the back, thank you.
He wants to go back there again for any. Thank you. So my question.
Through the gate or
Hey.
pick up at the gate. That there's so much evidence out there that really works. Ideally, it's great if you could meet the person before they're released, but if you can't, if there's no access into the prison, meeting someone at the gate, it's a bit like what Matt spoke about. It's like such a supportive action. It goes a long way and it builds trust, and sometimes we need to be quick and not wait around because we need to engage people as soon as possible. So that would be my advice.
Yeah, just to piggyback on what Julia said, I think, you know, we lose so many people from not picking them up at the gate. You know, so many people go directly back into their old environments and what they know, right? So if they were using a gram of fentanyl or maybe a couple points of fentanyl every hit that they were doing in North America, their first thought process is going to be like, that's what I want to do, right? That's what's going to make me feel comfortable. That's what's going to give me that warm hug. And they go, they do what they have to get the money. Maybe it's boosting. Maybe it's just doing a quick little drug deal. Maybe, you know, just something quick. And they do a shot and they die, right? And I think anything we can do that saves lives is just so astronomical to the work that we do, and it gives people like us a chance. And like I know a lot of these people that we picked up through PALS. There's some people that aren't here with us anymore, but I know it wasn't because they weren't picked up at that gate, right? They got to live another 4 or 5 years, a couple years. They got to find housing. They got connected back on their OAT. They got another chance at life, right? And I think as long as you're still breathing, we all have another chance. And, you know, no matter what people say, we can overcome whatever is put in front of us.
Thank you. And I guess if I could just add to that, there is something, as both have said, about building up that credibility and starting small and becoming visible and promoting the work, and then so that you can start outside the gates, but then move into, and also reach out to the other countries that have done it. Rachel's here from the Hepatitis C Trust, along with Stuart and Julia and Chrissy. Reach out. There's a whole wealth of information. That's one of the beautiful things about the International Network of Health and Hepatitis. We all work alongside each other. We collaborate. We share our ideas. So yeah. And did you want to add anything to that? No, thank you. Okay, we've probably got time for one more question. Lady at the back.
So my name is Leila from Kenya, and we also have the MAT services in the prisons. But my question would be, okay, do you think it's a risk that we have the MAT services in the prison without the peer outreach support? So yeah, that is basically my question.
So methadone-assisted treatment in the prison?
Yeah.
Yep.
Yeah.
Amber, did you want to take that one? No? Okay. Julia? So do we think that it's a risk having opiate substitute programs in the prison without that peer support alongside it?
Thank you so much for the question. And I think that it's okay to have it without the peer-led support, because you're giving it to people who desperately need it. This is something that I needed, that I wasn't given. So if it was available, I would have been very happy to have it.
Thank you.
And then I guess potentially if you start there, you can then build the peers from those people that have been successful in getting the methadone. So yeah, I think that's how the movements start. It just takes one person to step forward and galvanise action. So thank you. What I would say, the programme for INSHU this year is absolutely phenomenal. We've got more community speakers on the plenaries, on the main agenda, on poster tours than ever before. All my three panellists are all speaking, so please show your support and go along to their talks. They're going to be fantastic. And then I'm just going to do, I know it's a really long day, but I'm just going to do a quick plug before I let you go for a comfort break. Not about the scavenger hunt. I am going to win the scavenger hunt. I'm barred from entering. I'm very upset about it. Each year we host a early mid-career researcher and community networking event. It's after the community day at 4 o'clock. The background from that is a few years ago it occurred to a few of us that members of the community were a bit intimidated by speaking to academics and thought people with letters after their names might be super scary and look down on us. They might perpetuate that stigma and discrimination that many of us have felt. Conversely, the members of the academia world were scared to talk to us. They thought that they might offend us by asking us questions. They didn't know how to approach it. They would trip over themselves in anxiety about what they could ask, what they couldn't ask, what was appropriate, So we've been hosting this will be our 4th year of hosting a networking event. So our very own Angela and her colleague Andrew, who's the co-convener for the conference, are going to start the session by a little bit of a panel about talking about what it means to work with each other. And then we're going to have like a speed dating. There's going to be drinks, alcoholic drinks as well. Always pulls people in. So yeah, and we're going to go for a short break now, and then after that you're going to hear from Annie and the Unitaid team and the Frontline team and the other team that are doing the big project, and that just absolutely showcases what people who use drugs can do when they come together with researchers, academics. So thank you very much. Could we just give our panellists a round of applause? And if we could come back promptly at 2:45, that would be absolutely marvellous. Thank you.